distraction. The private equity firms impose management fees, charging the very institutions they supposedly came to help. They demand quarterly profits. They set productivity quotas with zero regard for patient care. They sell off real estate. Buildings that housed healing and served patients now become quick cash. They pay themselves dividends while the hospitals hemorrhage resources. Then, step 4, the final blow, the abandonment. After a few short years of squeezing every dollar out, after loading institutions with unsustainable debt, after stripping them down to shells of what they once were, private equity walks away. They sell to the next vulture, or they let the institution that they once said was so worthwhile investing in collapse into bankruptcy. Either way, private equity profits, and our communities are left with closed hospitals, shuttered clinics, and nowhere to turn when someone has a heart attack at 2 a.m. The goal of private equity is to engage in asset acquisition, restructure for the purpose of generating high returns for investors in the fund, typically in the 3 to 5 year range, not build long-term value or stability. On the front end of an acquisition, private equity firms can relieve healthcare providers of administrative responsibilities, infuse capital, enhance revenue cycle management, introduce operational efficiencies, and rescue failing healthcare systems. But private equity's focus on short-term revenue generation and investor profit can also lead them to strip those acquired facilities of their assets, force those entities to raise the prices through anti-competitive practices, reduce staffing to dangerously low levels, avoid investment in very critical infrastructure, and eliminate vital services to the detriment of our patients, our healthcare workers, and our entire communities. For this reason, private equity fund ownership is of deep concern in healthcare, where quality of care and patient safety are in the public interest. Our interest should be, and should be a healthcare entity's highest priorities. The data tells chilling stories. In 2023, over 20% of healthcare entities that filed for bankruptcy were owned by private equity. Over 90% of those at risk of bankruptcy, according to Moody's, were in private equity hands. Steward Healthcare in Massachusetts was acquired by private equity. They extracted hundreds of millions in real estate sales and management fees. And then in 2024, Steward filed for bankruptcy, closing 2 hospitals and leaving communities without emergency care. Here in New Hampshire, we've seen half of our maternity wards and birthing centers close in just the last decade. What happens when private equity gets its hands on the hospitals that remain? What happens to the North Country when the nearest hospital is hours away because a Wall Street firm decided that quarterly returns were not good enough? While no major hospital in New Hampshire is currently owned by private equity, that wasn't always the case. HCA owns over 160 hospitals nationwide, 5 of which are in New Hampshire. Not that long ago, it was acquired by a private equity deal with Bain Capital, Merrill Lynch, and KKR, private equity giants, for $33 million. The largest leveraged buyout in history at that time. The buyout saddled HCA with $12 million in debt, more than a third of the total investment. This loaded HCA with $12 million in debt, after which 5 years of controversial management decisions that led to a drop in quality patient care, dangerously low staffing levels, and multiple lawsuits, HCA was able to get out from under that ownership and restructure the debt, which it carried for over a decade after. While HCA is now publicly traded, there is nothing stopping private equity from re-engaging, and let's learn from that. And it's already happening in smaller ways. Primary care practices across our state have been quietly acquired. Dental offices, specialty care facilities. Some have closed entirely and replaced with urgent care centers because urgent care is more profitable, even if it doesn't suit the community's actual needs. We would be fools to wait until the devil is at our door. Senate Bill 666 is simple and just, and it requires advance notice when private equity firms try to acquire healthcare facilities. Senate Bill 666 requires transparency about debt obligations, management fees, executive payouts. Senate Bill 666 will require the Attorney General to review, to protect healthcare access, to protect quality of care, and to ensure competition. 666 will provide protection for clinical judgment so doctors and nurses can practice medicine, not be maximizing profits. This isn't radical. Colorado has done it, Illinois has done it, and Massachusetts, after watching Stewart's collapse, has done it. This is proactive protection, and the stakes could not be higher. Senate Bill 666 is clear in what it's protecting. When a hospital closes in rural New Hampshire, people die. When the nearest emergency room is over an hour away, heart attack victims don't make it. When maternity wards disappear, mothers and babies pay the price. And private equity doesn't care about any of this. Private equity firms care about quarterly earnings reports and investor returns. It's focused only on caring about extracting maximum value and exit strategies before the investment collapses under the weight of profitability maximization. Senate Bill 666 stands between Wall Street and our hospitals. It stands between profit-driven destruction and the care that our families deserve. And so, yes, this is Senate Bill 666. And you know what? The number is perfect because what private equity does to healthcare is predatory turpitude. It's ruthless. It treats human suffering as an investment opportunity and sick patients as revenue streams. So this bill is our way of saying, not here, not in New Hampshire. We will not let Wall Street vampires drain our hospitals dry. We will not let private equity demons close our maternity wards for profit. We will not stand by while our neighbors lose access to care because some hedge fund manager in Manhattan decided that the numbers don't work. So this is our exorcism. This is how we keep the devil out of our healthcare system. It's not a partisan issue. When your child needs emergency surgery, you don't care about party affiliation. You care that the hospital is still open. When your mother needs cancer treatments, you don't care about politics. You care that there are doctors available to treat her. This is our chance to work together to protect something that matters to every single person in this state: access to quality, affordable health care. So I urge you to support Senate Bill 666 because health care is sacred. It's about healing. It's about caring for our most vulnerable. It's about ensuring that when a crisis strikes, help is there. And we will not let Wall Street turn that into just another profit center to be exploited and abandoned. Respectfully, I ask the committee to recommend Senate Bill 666 ought to pass. Thank you. I've included in my testimony a packet from a symposium that was held at the University of New Hampshire in 2025 entitled Private Equity Ownership for you to look at on your own time and just get a little more background into what inspired this.
Thank you, Senator. I'm going to open it up to questions in a minute, but I did have a question for you.
Yes, sir.
You talked about the North Country and private equity acquisition. There are a number of rumors swirling in the North Country about a potential acquisition, whether they're founded or not, I don't know. Do you know something I don't know? Is there a private equity gaining steam to acquire hospitals in the North Country?
I don't think you and I have any more information than the other. I have heard, but I didn't put that. I don't have anything substantial to put into testimony that I would stand
All right.
behind.
Thank you very much.
But thank you for the question. Yeah.
Sure. Are there any questions from the committee? Senator Avard.
Thank you, Senator, and thank you for taking my question. Basically, I'm looking at the methodology, and it says the department shall evaluate, approve, or prohibit such transactions based on their impact on competition. So we're going to have the Justice Department take a look at their ability to.
Thank you for the question. What page? So I may be right
It's on the
there.
methodology and
On the back. Okay,
Yeah.
thank you.
And basically, it's just, the Justice Department will have, it's kind of vague to me. What do you mean by impact on competition? Will it not allow competition? How's
No, not at all. As I mentioned in my testimony, we don't want there to not be any competition. So private equity will often scoop up multiple practices. And so if you've got, 7 dentists in one particular county, but they're all owned by the same private equity firm, there's no competition there.
Wouldn't that be covered under monopoly, though?
Maybe. It has to go through, so as it stands now, things need to be reviewed by the Attorney General's office when forming a merger, but not multiple acquisitions. We're not talking about I'm not talking about mergers. I'm talking about scooping things up.
Thank you.
Any other questions from the committee? Senator Long.
Thank you for your testimony, and thank you, Mr. Chairman. My concern is with HCA. I know in the city of Manchester that CMC was going to close down. And I also know that HCA invested millions of dollars, I'm not sure exactly how much, but over the $50 million on equipment that was old. So I don't, and HCA has current hospitals that have been long-term here. I don't understand where you contemplate that they would be leaving once they gain their profit.
Thank you for the question. Let me go back to the outline of HCA. So it was back in the early 2000s when HCA was acquired by private equity. And that private equity was a collaboration, a joining of investment of $33 million between 3 different companies, Bain Capital, Merrill Lynch, and KKR. And in that acquisition of HCA nationwide, it left $12 million of debt to be spread out across all of those hospitals, but not before those private equity investment companies got their return. So it was by all accounts, unless of course you are a part of the Bain Capital, Merrill Lynch, or KKR group, it was not a successful experience for the HCA hospitals here in New Hampshire. So we're 5 of the 160. And so I believe it was 2011 when HCA nationally was able to go back to being a publicly traded company and get out from underneath the private equity ownership. When they did get out from underneath that, that was about 2011 or 12, I believe. But when they got out, they were still carrying the debt that was acquired in that first merger. So HCA experienced, and in New Hampshire, we had a death and a multiple lawsuits about quality of care because we had multiple patients who developed complications due to bed sores. We had multiple nursing staff complaining about a lack of ability to deliver quality patient care because of understaffing. And so, I mean, there are lots of complaints just from New Hampshire. So when nationally HCA got out from under this deal, which I think is was that going back to being publicly traded happened before any involvement with Manchester. So they're not really connected. How, other than to say that HCA in its newly publicly traded structure, when it first went back to being a publicly traded company, was still servicing the debt that was acquired from the saving grace of private equity.
Great, thank you.
Any further questions? I've got one more follow-up for you.
Yes.
So, and this is kind of tacks on to what Senator Long was getting at. And, you know, you talk about the debt and it sounds like a bad deal. Wouldn't it be incumbent on the board of the acquired facility to do their due diligence, to fully understand the debt structure? And some deals are bad, but I would think that they would have found that in their due diligence process and fully understood what happens to the debt, who gets paid first, where the cascade comes. I mean, how does this fix that?
So it doesn't fix it. What it fixes is that it creates a process by which we empower the Attorney General's office to review this possible acquisition by private equity, and in the process of doing it has a checklist of requirements that need to be met, which is that private equity firms cannot scoop up, dozens of practices, acquire healthcare facilities without advance notice to the state. And they have to be transparent in what their, going forward, what they're anticipating their management fees to be, what their executive payouts will be, exactly what the debt obligations will be, and how that will be filtered down to the different practices. The Attorney General will have to review what the anticipated promised protection of access to healthcare and quality care and maintaining competition. So it's not an unreasonable thought, because this has happened in other states, for a private equity firm to scoop up all the dental practices in a particular geographic area, and because they want to consolidate assets, close 3 or 4 of them, bring the equipment all into one place, but now you've denied access to certain parts of the county, right? Makes great sense on paper, but it doesn't make great sense for a for practicing medicine in the community. So that kind of planning needs to be shared with the Attorney General. It protects the clinical judgment of healthcare providers, so that the maximization of profits doesn't supersede the clinical judgment of the providers. So those are the new check marks. So right now we do have processes in place for when a new hospital wants to come online, or when one hospital wants to merge with another hospital. We have a process in place with the Attorney General's office for nonprofit health facilities. But what we don't have is the specific protections of what happens when private equity comes in and zeroes in not just on the acquisition of a series of hospitals, and HCA was my example in that's where we experienced it for a number of years here in the state. But what if now, for instance, methadone clinics are pretty much all owned by the same organization. So what if they now start scooping up other healthcare facilities or clinical practices for psychology? Like, then what?
Thank you.
Before that train goes so far down the tracks. We need to know, we need a lot more information.
Great, and we're fortunate because the Attorney General's office is going to speak next.
Fantastic.
All right, thank you very much.
Thank you. And if you'll excuse me, I am supposed to be in committee over there.
Totally understand. We traded places here, I
Yeah,
think.
thank you.
Yeah. So the chair is going to call Alexandra Sosnowski from the Attorney General's office.
Hi, good morning.
Good morning.
Chairman, members of the committee. My name is Alexandra Sosnowski. I'm a Senior Assistant Attorney General at the New Hampshire Attorney General's Office in the Consumer Protection and Antitrust Bureau. I'm here today in support of this bill with some points to consider, and we're open to working with the prime sponsor, but we have some things I think for the committee to think about in this bill. So first off, there is no required notification to the Consumer Protection and Antitrust Bureau for a transaction, for even a hospital transaction. There is a required notice for a nonprofit hospital transaction to our charitable trust unit. So that's usually how we get notice, and we have a good pulse on the number of hospitals in the state and what's kind of happening at that level. We do not have any insight right now because there is no required notice about transactions that are happening below the hospital size. So physician practices, it could be a group of anesthesiologists that could be getting together and we don't know about it. So that is something that could be happening. This is one of those bills, you don't know what you don't know. So I just point that out to the committee. So we don't receive information on transactions that are occurring or might be occurring below the hospital level right now. This would allow us the opportunity to have insight into these transactions, review them and decide, make a determination if we want to open an investigation further into some of these competition issues that are laid out in the bill. So a couple of things to point out. The bill requires the Consumer Protection and Antitrust Bureau to review within 30 days of receipt of notice and determine its likely impact on competition, cost of care, access to services, quality, and financial stability. This is an insufficient time frame to complete all of those tasks. It may be possible, and this is where we would want to work with the committee and the sponsor, if we had all the information necessary to determine whether in 30 days we would want to open an investigation for further inquiry and kind of gather more information. But those factors alone could not be completed in 30 days, even if we have the staff resources. And it's also unclear in the bill what action is required of DOJ after those 30 days. So is it like a 30-day waiting period? Is it a required no action on our part? So there's some ambiguity there on what our obligation is. I'll point out that the Consumer Protection Act is mentioned, which is RSA 358A. And we also primarily conduct our merger reviews under RSA 356, which is the Combinations and Monopolies Act. This bill requires an annual public report detailing the transactions reviewed, the actions taken, observed trends, and recommendations for legislative action. When we conduct a merger review under RSA 356, it is a confidential, non-public investigation. This allows us to speak to stakeholders in the market confidentially and get information that is highly sensitive and highly impactful on competition in the market. Those assurances are necessary in order for us to get the necessary candor from individuals and organizations that we speak to. So I would have a concern about the public report and what is actually required in that public report in order to not compromise the integrity of an investigation and the ability to bring enforcement actions if necessary. And lastly, I did the fiscal note on this, so you will see the resources required. I am the primary attorney responsible for antitrust in this state. And so in order to really do this work, we would need an in-house economist in order to assist our office. Right now, when we conduct a merger investigation, there's a part of the statute in RSA 356 that allows us to contract with consultants. So we hire out experts, and those costs are a direct charge to the parties involved in the transaction. So we do not have an in-house person that does this work besides myself, but we don't have an economist to do the necessary work in order to assess competition. And I'm happy to take any questions.
Thank you very much. I have a few here for you. So the 30-day timeline stood out to me as well, because I know sometimes these can take, we talk about these mergers, years to go through that. So what are we talking about
I
here?
agree. I think our reviews typically from start to a negotiated agreement, which is how we've settled most of them, it's a year to a year and a half, but that is a full-blown investigation. Whether we would need to do an investigation in all of these is unclear, but in order to make some sort of determination of yes, investigate or no, I even think that 30 days is pushing it.
Okay. And then another question is, you said you need an in-house economist. I understand as you are today, even without an economist, your department is stretched pretty thin. So I'm thinking just one economist is probably not enough.
Yeah, the fiscal note provides for an additional attorney and a paralegal as well.
Okay.
The economist is kind of the main
All right.
thing that we would need in order to really do this, but we would also need, depending on how many, because we don't know what we don't know about how many filings this could be, we are also requesting an attorney and a paralegal position.
So, and then my final question for now, you talk about looking lower than hospital level. So I think of my brother, for instance, a dentist, and there's not a lot of dentists coming into the state of New Hampshire. And once you get to a certain age, you don't want to, you kind of want to practice, get out, retire. And one of the struggles that profession has is finding people to buy a practice, an individual to buy a practice. So oftentimes looking to private equity is, a way to, transition a practice out. So, he decides he wants to practice, we pass this law, he decides he wants to retire. Is he now at the scrutiny of CTU on whether or not, it's justifiable that a practice that he's built up for his entire life and wants to take out of that practice all the sweat equity that he built up? Who's the state to tell him who he can and can't sell his practice to?
Yeah, thank you for the question. I think it would require a notice to our office under this law, and I think we would have the opportunity to look at, that private equity firm, what else that they've already acquired, and whether there would be an impact on competition in the dental market in the particular geographic area, and whether it would warrant, further scrutiny.
So he, God forbid, has a health issue, so I can't practice anymore, and he could either sell and get or close his practice and just walk away with nothing.
So I think I think our office takes a holistic view on these things.
And I do, I
right?
agree with you. I think I've worked with your office. You do an excellent job, and I'm not.
And so I think it's really facts and circumstances of the decision to sell, the conditions of the market, and what would be left, if that was the only dental office, right, in a geographic area.
You could have zero if he closes,
Right.
or have a private equity owned practice.
Right. And so those are the things that we take into account in the hospital market, and I believe we would as well, that it's not just ownership or not.
Sure. Thank you. Are there any other questions from the committee? Senator Ybarra.
Thank you. Thank you for being here. So what would be the trigger for an investigation? What would be a scenario like that? What would trigger an investigation?
Yeah, thank you for the question. It's hard to say in the abstract. I think we would want to do kind of an initial economic analysis of the market, of the dental practices that are in a particular geographic region, what the antitrust case could look like, just in as an initial screen. And then if we think, oh, that may be a problem based on the others in the market, if we've talked to anybody, and then that would require further investigation, which could include subpoenas, interviews, talking to stakeholders, others in the market.
Yeah, so I'm looking at the scenario, somebody's sick, I gotta sell my practice. I don't have any buyers and time is limited, maybe I got pancreatic cancer and I'm on my way out. I need to do something for my family. Now we're talking about a potential investigation if we can't find a buyer, because I do have a firm out there that's looking at this. How does that work?
Yeah, thank you. I think it's a balance, and I think and I have heard from other states that have passed similar laws, and they kind of start to get a sense of what's going on in the market and kind of where there might be problem areas or developing problem areas, because they start hearing about these transactions and they start hearing about private equity that might be starting to buy, and so you start to get kind of a landscape and where there might be problems or where in the future you could see problems. So it's hard in the hypothetical to know what you don't know.
But that does look like a real life scenario.
It's a potential.
Right. Yeah?
Yes.
So I caught this little, you said even if we had the staff. So you're looking at how many for staff?
An attorney, a paralegal, and an economist
Okay,
for the 30-day time period, I think, right, depending on how many we get,
right.
which I don't know.
And one more follow-up.
Last one.
Yeah, this is gonna be my last one.
Yeah.
Yes,
Come
absolutely.
back to you if you want.
All right. You did say you support the bill, but there are some changes. Where would the changes be directly in the language? Just not just the 30 days, but there's some,
Yeah, I don't have any specific recommendations right now. I'm open to working with the committee and the sponsor. We just didn't have the time or capacity to get kind of those types of changes. But I think the things I highlighted would be areas that we would want to address in the bill.
perfect. Thank you.
Thank you.
Senator Birdsell.
Thank you, and thank you for taking my question. So if someone were to sell, and I thought I heard you say that the players would have to pay for the review.
Yeah.
Okay.
Thank you for the question. So in a hospital transaction right now, we have a particular statute where if the parties are planning to merge, they will come to us and they foot the bill for our economist, our outside economists. And that's only a hospital transaction.
Okay, that and follow.
Yes.
And that is not in this piece of legislation?
That's an existing law.
Okay, so if this were to pass and we would get into a scenario, then both parties would have to pay for the economist.
Nope. So under this bill, we are asking for the staff resources in order to do it, to do the reviews, and the hospitals would still be under that direct charge component.
Okay, so you would have a staff just to handle these, and then the hospital mergers would continue the way they are.
Correct.
Okay, thank you.
Thanks. A question.
Senator Avard.
So you have staff already that can do this with the hospital?
We hire outside consultants to assist our office in a hospital merger transaction, which is paid for by the merging parties. We do not have in-house staff. We don't have an economist to do this. I am the attorney. Yes.
Thank you. Are there any other questions? So, Senator Birdsell?
So getting back to that question, why couldn't you do the same thing in this particular case? Hire outside consultants just for that? Because I'm not sure how many cases this would be, but why would you need permanent in-house versus consultants?
Thank you for the question. I think it would be hard to contract in that way, not knowing what the filings that we would get and the work that needed to be done. in order to get a consultant up to speed on the process and that sort of thing, that takes time. I mean, we engage our consultants for a year of our reviews. I think it would be more efficient to have someone in-house that can look at these and make a determination more quickly than if it's a consultant. And I think over time, you kind of build that expertise on the market and that sort of thing.
Any other questions? So I've got a couple things to close with here. We're under a very short deadline. We've got to get a bill like this with a fiscal note out in 2 weeks. Would you agree that this is a very complicated issue? Based on the questions you've heard, based on the fact that, you know, Senator Avard asked you for specific issues and, you know, you conceded that there are a lot of issues with this. I'm just wondering if this is a lot to tackle. This is a new concept for this committee this year. I'm just nervous that 2 weeks is not going to give us enough time to adequately examine this topic.
I think there's some fine tuning that would be required for us to adequately enforce this law.
Okay. All right. Thank you. Chair calls Ben Bradley.
Morning, Mr. Chairman, members of the committee. Thanks for the opportunity to testify on this bill. I represent, I work for the New Hampshire Hospital Association, represent all hospitals in New Hampshire. We are opposed to this bill as introduced. We weren't involved in the drafting, but do share some of the concerns that have been outlined around private equity acquisitions, particularly what was mentioned in Stewart's in Massachusetts, a really troubling case. My testimony is focused on Section 3 of the bill, which establishes new regulations and additional criteria governing healthcare transactions in Title 31 of New Hampshire's revised statutes on trade and commerce.
What page is that on?
So Section 3 begins on page 2. Let's see.
I don't see it, Ben.
Let me see here. That's what I had noted, but let me look back. Oh, it actually begins on page 1, line 11. But really the crux of my testimony is going to be around page 2, line 13 and 14. So these new regulations would run parallel and in addition to the existing regulations in RSA 719B when involving healthcare charitable trust, adding costs and delays to an already costly and burdensome process. While we appreciate the sponsor's interest in scrutinizing transactions involving private equity, Section 3 captures transactions already, as I mentioned, under review by the department that do not involve private equity. Particularly page 2, line 13 and 14. The Hospital Association does support the work that the DOJ and Charitable Trust Unit does in reviewing transactions that come before it under the existing statute, but we don't support the new added regulatory requirements in the separate statute as prescribed by this bill. As I mentioned, they can be incredibly costly and timely, and we are concerned that running in parallel with additional regulations could add to that. Appreciate the sponsor's interest and happy to work with her, but given it was introduced late and it raises concerns with those issues, we can't support the bill as it is and don't believe it should move forward. So happy to take your questions.
Are there any questions from the committee? No, thank you very much.
Thanks, Senator.
Anyone else that want to speak on Senate Bill 666? With that, we're going to close the hearing.
It's 3 FNs.
All right, well, there you have it.
Thank you. He's going to let me play chair now. Sophie, you're ready, right? So we're going to open up the hearing for SB 664FN and hear from the prime sponsor.
Thank you very much. For the record, my name is David Rochefort, representing Senate District 1, which is the North Country and a third of the area of the state of New Hampshire. Just want to pose a question to this committee. How hard is it to fight for Medicaid dollars? I think we struggle with Medicaid dollars every day in this committee. They're hard to come by, they're hard to allocate, and they are becoming a dwindling resource in many aspects. Next question I ask is, where do these Medicaid dollars go? In New Hampshire, we know they go, a lot of them, to hospitals to provide valuable care. Care that is becoming harder to come by. We heard a previous testimony in the previous bill, concerns about where our people are going to receive care, where are they going to get access to care, and is that care going to be able to be maintained? So the question comes is, where are we spending our Medicaid dollars and where are they going? So it's come to me over the last several months that there's a number of dollars that go to executive compensation. And what does executive compensation mean? So just to give you an example, and I want to also point out that this body a year ago designated Coos County as a place-based distressed economy. So the legislature acknowledged publicly that Coos County is in distress. Our economy is struggling, our people are struggling, and the state, through the legislative process, recognized the fact that Coos County needs a little extra help. So I want to get to where we're at right now. Critical Access Hospital, and these are not in Coos County. CEO pay, $516,000. Another Critical Access Hospital, CEO, $278,000 a year. Another one, $443,000 a year. Another one, $487,000 a year. Another one, $404,000 a year. Another Critical Access Hospital, CEO pay, $448,000 per year. That's funded primarily in these hospitals by public money, money of the taxpayer. You go to Coos County in a distressed economy, and we're starting off a CEO pay of $700,000 a year. So that is what this bill is about. Where is our public money going and what are we spending it on? I can tell you right now, from reports I'm hearing, Colebrook Hospital does not have a doctor. Not a doctor in Colebrook Hospital. Other areas have access to primary care, but there's no doctors there. Having trouble recruiting. We heard yesterday that they're spending $200,000 as a sign-on bonus to get doctors to come to Coos County. So we got to look at where is our money going. And that's what this does. And the other thing I want to note is in one of these systems, they laid off potentially, they announced a layoff of up to 70 people in one of these departments. One could say, we're laying off people, we're outsourcing jobs in order to make things more efficient. And as a business owner, as someone who has operated in the healthcare space, I 100% get it. But not once have I ever laid off an employee to give myself a bonus. I've never used public money to do it. So that's really what this bill is about. It says if you're laying off people, which doesn't say you can't lay off people, it says if you're laying off people or things are so bad that you're laying off people, that money, that public money, that taxpayer money cannot therefore then go to pay a bonus, a increase in raise salary. It's not a foreign concept. I think any business owner in New Hampshire, any small business owner who has been faced with the same decisions would understand that laying off people, outsourcing people is a very serious, it's a very contemplative issue. And I can tell you, I've never talked to a small business owner that's had to lay off an entire department only to ensure their family could go on vacation or get a bonus that year. And that's really what this gets at. And I know it's controversial. I know it's, somebody said, Dave, this is not a very Republican bill. This sounds more like something Bernie Sanders would propose. I think it's something we have to look at, because at the end of the day, this isn't private business. The state isn't putting their nose into private business. This is our money. This is the money that we fight for every single day. We've debated it here in this committee at this table, good programs, things that can help people, but we just don't have the money to do it. And we can talk about whether it's mental health, whether it's substance abuse, or whether, wherever it is. But I think at the end of the day, those dollars are hard to come by. And this just holds the people that are receiving those dollars, puts a little bit of accountability there. And it's not, it's not an excessive ask in this bill. It's temporary, temporary hold on bonuses and salary increases. And that's what you have before you. I know it's a controversial topic. I know we're going to hear a whole bunch of people that tell me how crazy I am to do this. But, when you start looking at the facts and you start asking questions, and we as this committee are posed with the difficult questions that we're posed with, and we have to make the difficult choices that we have to make down here, deciding who gets that dollar for care, because whenever somebody gets one, somebody misses out on one. And that's what this is about, making sure that, if the tough decisions have to be made, we're not subsidizing somebody else's bonus. So I'm happy to answer any questions. If you've got any, feel free to ask them.
Questions from the committee? Senator Long.
Thank you, Mr. Chairman. Thank you for your testimony. I certainly get this. I'm a co-sponsor on that, and glad to hear the Bernie Sanders reference. Now, temporary hold on bonuses and salary, would rulemaking establish how long that would be?
So I think that we have the freeze shall begin on the date the workforce, it says when it goes into workforce reduction, the freeze will begin on the date the workforce reduction is initiated, and the goal was for 18 months after that. So if you look at page 2, line 12 and 13, any hospital located in a distressed place-based economy that conducts a workforce reduction affecting more than 10 employees in a single department within a 6-month period shall be subject to an 18-month freeze on C-suite executive compensation. So it's just 18 months. It's a year and a half.
Very good.
And I think when we talk about the salaries here, we all work for $100 a year. I think that 18 months is not a long time given the number that we're talking about here.
Right.
I know when I was in business, I went years without a salary increase.
Further questions?
Thank you.
Senator Prentice and then Senator Bertzel.
Thank you, Senator Avard, and thank you, Senator Rush, for taking my question. So this is strictly for distressed area.
Yes.
And Coas County has been designated as such in the last legislative session. And it would freeze compensation for 18 months. It limits it for that period of time.
Correct. It freezes it from any bonuses, any raises, for 18 months. It doesn't claw anything back. There's no clawback provision on that. But what it says, so the message is you're operating largely on public funds. If you're laying off people, and that's what's best for your business, and that may be the best for your business, because these institutions operate largely on public funds, that those things are so bad you got to lay people off, that we shouldn't be using those public funds to enhance, to give bonuses, to extend pay,
Quick follow-up.
increase pay.
Thank you, Senator Rushford. So this doesn't change an initial compensation package, set a ceiling or a floor. It freezes it for a period of time under certain conditions.
Yes.
Okay, thank you.
Senator Britzel.
Thank you, and thank you for taking my question. So getting back to line 12, 13, and 14, where it says reduction affecting more than 10 employees in a single department within a 6-month period, couldn't they buy the system and lay off 5 employees and then on 6 months and 1 day, another 5 employees and still not be?
Yes, that could happen. That could happen. And that's why I kept the number a little bit lower, because, I initially had drafted this with a higher number, realizing it's much easier to do that. If the number is higher, you could move people around for that period of time. So I intentionally lowered the number to, and, if you're going to game the system, you're going to game the system. I mean, we're all, this is what we do down here, is it seems like we're always one step behind of that. But that's why the number was intentionally set at 10 to lessen the ability to do that.
Thank you.
Further questions?
All set?
No, I.
Oh, all right.
You know me.
I thought you were waving me goodbye.
No. Hello. So what happens if AI says, well, we've got this AI product and it's going to eliminate, say, 20 jobs, and it makes sense, and those individuals get at least laid off and then moved to, or in a lateral position to another position in the hospital where they can, does this still trigger that, your event?
We're never gonna, AI is coming. And for any industry in the country to think that AI is not gonna have an effect on you, you got your head buried in the sand. AI is coming. I think we're shouldn't say we're a long way. I think we're a little ways off before we get AI to the point where it's dramatically affecting. And I could be wrong on this. I mean, I can think of a couple instances where AI is working and doing a better job on that. But at the end of the day, this is only an 18-month freeze, and it's not forever. It's not. And if you revolutionize a department and you were able to completely replace that with a robot that works 365 days a year, 24 hours a day, doesn't take a holiday, doesn't call in sick, doesn't, complain that they have a stubbed toe, and you can provide patient care, that great. Quite frankly, I embrace that. But this is not saying you can't do that. And this is not saying we're gonna protect ourselves from AI by putting this bill in. It's just saying, if you're going to do a mass layoff and you're going to find those efficiencies, just hold on for 18 months before you take that bonus.
My concern is that this might set a precedent in the spirit of Bernie Sanders, where the state would get involved with other situations like this. Kind of struggling with this.
Can I answer that?
Yeah.
So I'll respond to that. So I think that it will set a precedent. And believe me, I've heard both positive and negative about this bill, far more positive than negative about that. But we just heard testimony a minute ago about the state getting in between a dentist trying to sell a practice. I don't believe this is as far reaching as that. We set precedents all the time in this state. But at the end of the day, the way I reconcile that, this is public money. This is taxpayer money. And I think good jobs should be awarded and rewarded, But when you're largely dependent on public money, I think we as the legislature have a say in that and have a role in that. We talk about it all the time down here, where that public money is going and where it's not going. But to say that this is, I wouldn't say this is private industry. This is quasi-private industry because it's almost entirely dependent on public money. So we as a legislature do have a say where that, we do it all the time. And I think that's where that's where I've been able to reconcile that in my mind. And it is, you're absolutely right, Senator. It's going to set a precedent.
Thank you. Now you may go.
Thank you.
Anyone ask you to talk?
Thank you. I appreciate that. Chair calls Representative Corzine.
Thank you, Senator, and members of the committee. My name is Lori Corzine, and I represent Coos County, District 7, which is Berlin, Jefferson, Whitefield, Kilkenny, and Twin Mountain. I ask for your support of SB 664 to bring fairness and accountability to hospital executive pay, particularly in Coos County. In the past year, many of my hardworking constituents have been laid off from positions they held for years, some for decades, not through any fault of their own. Their jobs were outsourced, some of them out of state, some of them out of the country. Meanwhile, the hospital was still allowed to give executives bonuses. The people of Coos County and those jobs are hurting because of that job loss. This bill just makes sense and brings some accountability back. I ask you to really consider this bill on behalf of the people of Coos. Thank you.
Thank you, Representative. Are there any questions from the committee? No, thank you very much.
Thank you.
Thank you for coming down today. Chair calls Steve Onen.
You're setting precedent. Not a bad idea, though.
Good morning. Mr. Chairman, members of the committee, for the record, my name is Steve Onen. I'm the president of the New Hampshire Hospital Association. I'm here representing all 26 of the state's community hospitals, as well as all of our specialty hospitals. Hospitals in New Hampshire are privileged to do the incredibly important work they do every day to care for the patients and communities who put their trust in them at often their most vulnerable points in their lives. The environment facing hospitals today is ever more challenging. A recent report from the Hospital Association shows that increased demand for healthcare services, workforce shortages, barriers to discharge, insurance delays, and much more are raising the cost of providing care while revenues are not keeping pace. In 2024, 7 hospitals in New Hampshire, including 4 rural critical access hospitals, were operating in the red with a statewide operating margin of 1.6%. Labor costs have increased 36% since 2019, and hospitals have seen an increase in total operating expenses of 44% in that same time period. I've often said that running a hospital or health system is one of the most challenging jobs in America. That continues to be true today, but even more so for rural hospitals and health systems. Lower patient volumes, larger numbers of uninsured patients, and a heavy reliance on Medicare and Medicaid programs that do not cover the full cost of providing care, as well as major federal cuts of the Medicaid program, make operating in a rural environment much more difficult. The New Hampshire Hospital Association is opposed to Senate Bill 664. It is a rather imprecise effort to target an organization's leaders for making difficult decisions that are designed to ensure their organizations can continue to care for their community today, tomorrow, and for years to come. While the legislation today focuses on hospitals located in an economically distressed community, it doesn't take one long to believe that those same requirements could be placed on any other hospital, or for that matter, any not-for-profit organization. This opens the door to a place New Hampshire hasn't been before, with government stepping in to regulate compensation for private entities. Clearly not the New Hampshire way. There are many issues and challenges surrounding this bill, but let me focus on three. One, this bill would seek to penalize the executives of a hospital in an economically distressed community if they were to cause a reduction in their workforce impacting more than 10 employees. But what if the hospital chose to partner with a local food service vendor to outsource its cafeteria services, for instance? If all of those individuals were to become employed by that local partner, under this bill, those hospital executives would be penalized for making a decision that strengthened the hospital's financial position while still ensuring that those employees remain employed and working in the hospital. Two, the Rural Health Transformation Program will create a tremendous opportunity for us in New Hampshire to help stabilize the healthcare system and to provide investments for new innovative technologies. New Hampshire will receive $204 million a year over the next 5 years, a tremendous investment, the largest award in New England. If new technologies or models of care are implemented that can improve healthcare access and outcomes, but that causes a workforce reduction of more than 10 employees, are we to turn that down and walk away from that innovation? And three, this bill takes local control away from hospital leadership and community board oversight. Executive compensation is determined by community leaders who serve on the board of the hospital. They're business and other civic leaders who give their time and dedication to oversee the work of the hospital. They follow a thoughtful, deliberate, and transparent process in determining executive compensation based on federal and state rules and the demands of the market for recruiting high-quality leaders. Compensation paid to these CEOs and executives is transparent and reported annually in compliance with federal and state requirements. Their hands would be tied for making important fiduciary decisions if this bill were to pass. I believe our shared goal is to ensure our rural hospitals exist to serve their communities long into the future. Tying the hands of local boards to recruit and retain top leadership will only make that job more difficult. For these reasons, we strongly encourage the committee to recommend ITL on Senate Bill 664. I appreciate the opportunity to share some thoughts with you. Be happy to take any questions you might have. But just one other thing I wanted to point out. Mr. Chairman, you talked about the challenge of finding Medicaid dollars to support all of the services and programs in Medicaid that are necessary. I just want to remind the committee, we spent a lot of time last year in this committee talking about something called MedDish. And I want to remind this committee that hospitals paid $348 million in Medicaid enhancement taxes just this last year. As a result of the agreement that we reached with the governor and the state, that will result in almost $1 billion in Medicaid spend, including to hospitals, across the Medicaid program. So the fact of the matter is the hospitals are paying a significant portion of the Medicaid funding in the state. We're proud to do it. It's important, not just for hospitals, but it's important for behavioral health providers, substance use providers, long-term care, and many, many others. So just want to make sure that that's noted in my remarks. Happy to take questions.
Great, thank you, Steve. Are there any questions? Senator Long.
Thank you, Mr. Chairman. Thank you for your testimony. Your example one of the cafeteria workers was to what the hospital would increase its profit. Do you think it would be fair for some of that profit to give a bonus to the CEO?
Again, executive compensation is determined by the board of the hospital, by local community members who, looking at national data, understanding what it takes to recruit and retain those executives, would make. Those decisions would be made by the board. And I guess I just want to also point out, over a couple of years ago, we all remember the Change Healthcare cybersecurity attack. Had significant implications for hospitals in New Hampshire, particularly the hospitals in the North Country. I believe 97 or 98% of the revenue that came to the hospital stopped because of that cybersecurity attack. The hospital never once stopped caring for its patients, never stopped taking those patients, seeing those patients. They dealt with that. they use their reserves, that because of the sound business decisions that they've made over the years, allowed them to do that, and they made sure that patients continued to get the care that they needed. So again, I think, you know, those organizations, those boards, those hospital leaders are going to make decisions about what's best for the long-term future sustainability and viability of that organization to be able to serve patients not only today and tomorrow. You know, many of these hospitals have been around for 100 years or more. They'll look very differently 5, 10, 20 years from now, but the important thing is that they remain and they're able to continue to providing that care that their patients need.
I have a follow-up question.
Absolutely.
Thank you. With respect to the boards, I understand that the Board of Trustees compensates the CEO. Have you ever seen where the board was concerned about the CEO maybe leaving and would need to compensate him? And that would be a reason for a bonus?
Again, those decisions will be made by the board based upon what they believe is in the long-term interest of their organization. It is their fiduciary responsibility to ensure that they have the right leader to lead their organization, and they will make decisions based upon the future of their organization, and compensation certainly is a piece of that, but it's not the only piece.
Sure. Okay, thank you.
Senator Birdsell, you have a question?
Thank you, Mr. Chair. Thank you for taking my question. While I'm not totally enamored of this piece of legislation, but dovetailing back on what Senator Long was talking about, you say in your comments those hospital executives would be penalized if they found the cafeteria services, would penalize for making a decision that I don't see where it's being penalized, because they're already, all they're doing is freezing it. They're making somewhere according between 200 and 400,000 a year. So I don't see where they're just being penalized because they're not going to get a bonus for 18 months. Can you explain that to me?
Again, my statement I think is very, very true, which is they're making decisions based upon what is in the long-term best interest of the organization. If they make that decision to outsource or to change how they're doing things, they are doing that for the long-term sustainability of the organization. Executive compensation takes into consideration a whole host of things, not necessarily one particular action. But what this is saying is, because you've taken this action that has caused a reduction, despite whether or not that is improving the long-term financial sustainability of the organization, to be able to sustain things like the Change Healthcare cyber attack, you're penalizing them by saying, just because you're doing that, we don't think that that's appropriate. And you know, we believe that that is a decision that the Board of Trustees is able to make based upon their view of what's in the long-term interest of that community, because they represent the community.
And just want to clarify, Senator, you're right. Most hospitals of this size that we're talking about do compensate their executives between $200,000 and $400,000 a year. But in a place-based distressed economy, that actually is exceeding $700,000 a year. Any further questions of the committee? Thank you very much. I've got 5 signed up from North Country Healthcare. Do you want to come separately or do you want to come together? Totally up to you. Okay, then the board calls Corinne Cascadden. And I'm sorry, Corinne, I would have, if you'd put Honorable Corinne Cascadden, I would have had you come speak sooner, so I apologize. Thank you very much.
Good morning, Mr. Chair and committee members. Thank you for allowing me to testify today in opposition of Senate Bill 664 FN. This bill is a discriminatory bill that goes against your beliefs of free market private business and counters the platform to eliminate government overreach. I am Corrine Cascadden, a former systems leader in Berlin, Littleton, and Lyme. And for those who don't know the real needs of people living in the poorest rural area of the state, access to health care services is an absolute necessity. Not only is access critical, but access within the geographical region is what saves lives. North Country residents want and deserve excellent care close to home. I volunteer to serve as an NCH, meaning North Country Healthcare, I'll refer to it as NCH, board member, and as a Weeks Medical Center board member. I have immediate family members who have and are currently working at the 3 hospitals in the NCH systems as professionals, and I am a patient of the system. In 2025, our hospitals served 60% of Coos County residents. Our 3 hospitals saw 18,862 unique patients, and our home health and hospice affiliate served 1,112 unique patients. Yes, Coos County is a neon light as the New Hampshire economically distressed region, thus exacerbating healthcare recruitment efforts. Staffing shortages are real, not just in North Country, but they are real in multiple avenues all over the place in terms of staff shortages. We know this is a huge challenge. This designation of economically distressed region does not attract leaders or patient providers. As board members, we must be vigilant in ensuring that we attract talented leaders to our health system. Our patients deserve it. Rural hospitals are closing throughout the country at an alarming rate due to financial challenges. A recent study found that 700 hospitals were vulnerable for closure this year, and 4 of those in New Hampshire. The healthcare industry is very complex and highly regulated. Attracting strong, thoughtful leaders is essential to the success of a hospital. That is made even more complicated when we are competing to attract talent in competition with health systems in more urban parts of the state. As board members, it is imperative that we attract talented leaders because our patients deserve the best we can provide them. At NCH, we've done that. Since its inception, NCH has generated a positive operating income every single year. Even more remarkable, it has exceeded its budgeted operating income annually. In an industry where missed budgets, operating loss, and financial improvement plans have become commonplace, this level of consistency is rare. It reflects disciplined leadership, realistic financial planning, and an organization that executes with intention rather than reacting in crisis mode. Simply put, this is not luck. It's the result of having talented leaders who make strategic business decisions. I'd like to go through parts of the bill, starting with part 1 of this bill. And in the section states, stability is critical to the health and economic well-being of the communities they serve. Without highly qualified staff, there is no service. This bill will not promote stability. It will put our 3 hospitals at risk because it ties the hands of our executives. Part 2 and Part 3 of this bill, the state's reductions have included layoffs exceeding 10 employees. Please do a fact check. And I want to thank Senator Rochford for attending the community listening centers because that layoff question was clearly answered. Establish a law based on investigative reporting. If a service line is eliminated or replaced by another, it could impact 10+ employees. Businesses need to have the ability to make smart business decisions that are necessary for the industry. How does the state know the business or the needs of the people? Pretty similar to your question earlier, Senator Abard. Part 4 of the bill states allowing executive compensation to rise. This explicitly dictates compensation guidelines to set the organization up for failure. Compensation in nonprofit healthcare is highly regulated. And I say it again, it is highly regulated. It's not an arbitrary number. We say, okay, hey, we'll give you $1 million this year. It doesn't work that way. Salaries rise with market and are benchmarked to market. Part 5 of the bill, where it states the New Hampshire Attorney General's Charitable Trust Unit has unique statutory responsibility to ensure fidelity to charitable purpose. The CTU has this authority today. It doesn't need this law to continue its work in oversight. Nonprofits must cooperate and we must comply with their guidance and directives, irregardless of this law. And excuse me, Senator Rochford, I wanted to thank you in part while you stepped out. I want to thank you for attending the listening centers because the fact check that I'm suggesting on the reductions of the layoffs, you were there to hear those responses. So I just wanted to thank you for that. All right, going back to part 6 of the bill, the general court finds it necessary. Again, government overreach when there are checks and balances governing the healthcare system to benefit the patients in the service area, not someone who has minimal experience nor resides in an economically distressed region. The definition section is equally problematic under workforce reduction in that definition. This overly broad definition includes the involuntary termination of an employee. Consider this scenario. If an employee inappropriately shares confidential, protected health information of a patient, today that can result in termination under current hospital procedure. This bill would include that appropriate termination as one of the 10 employees that would trigger this law. Nothing in this bill can mitigate the challenges of providing high-quality health care in Coos County. North Country Healthcare is the largest employer in the region north of the Notch. It employs 1,100 people. Operations of a healthcare system, particularly since recent Medicare and Medicaid cuts, require high-level skill sets. Sometimes this requires elimination of positions or adding positions to efficiently provide high-reliability patient care. We cannot put constraints of this nature on our leaders, and we certainly cannot target 3 hospitals while allowing the other 19 nonprofit hospitals and the 4 for-profit hospitals in the state to continue to operate without any of these limitations. The North Country is a region of the state that has no estimated population growth based on the New Hampshire Fiscal Institute of Policy's research. Coos County residents are significantly older than those in other counties and have more chronic illnesses. If any one of the NCH affiliates were to close, NCH patients will be at increased risk for delayed or denied care. For example, chronically ill patients in Pittsburgh or Stratford could die if they had to travel an even greater distance to get care. The mission of North Country Healthcare, as you probably would all agree, healthcare is to improve lives by ensuring consistently excellent integrated healthcare. Our vision is healthy and empowered rural communities supported by our model of excellence and sustainability. This is what the governance board focuses on and lives by for the people in the North Country. We know it is not without its challenges, and there are many, as driven by the healthcare industry at large or for ongoing operational changes. This means that decision-making and leadership skills to best serve our patients are a necessity. And Senate Bill 664 is irrelevant to most and is a legislative intrusion on those leading a complex society, intricate system of care. This bill targets one New Hampshire healthcare system, a system that has received national accolades for its structure and organization. Recent examples of North Country Healthcare's success include NCH's ethics frameworks identified by the American College of Healthcare Executives Congress as strong infection prevention results. Androscoggin Valley Hospital has been designated as a level 4 trauma center, and NCH is surpassing industry standards for medication administration safety. To maintain and sustain NCH and all its 4 affiliates in northern New Hampshire, please act diligently to ITL Senate Bill 664 in committee. Thank you for your attention.
Senator Ebert.
Thank you. Thank you for your testimony. So you sit on the board, correct?
I do.
Yes. And this bill would basically handcuff you from making certain decisions as in some respects?
In some respect, yes.
Yeah. You did may?
Yeah.
Yeah. You did mention that there was a public hearing with the people that were being laid off. What happened to those people?
I'm sorry, I think you said something about public hearing.
What, wasn't there a public hearing and people were laid off from the hospital or I believe, if I heard you
Well,
correctly?
what had happened is we had community listening centers,
Okay.
and they had been scheduled a while, and we worked with New Hampshire, the Carsey Institute on, had 4 listening centers in each of the area communities, and we had one session with the area community partners, you know, all the nonprofits that support each other as a team. And it was really designed for small group discussions because people had heard a lot of rumors. And I certainly caution you against any social media garbage because it's not accurate. But it was designed so people could really express their concerns of what they're hearing, what they think, what went on. And so those conversations went quite well. I attended all the sessions. And I think that there were some very valid points. And I think as an organization, you're never great unless you're in a constant improvement mode. So I'm a strong believer of if we get any guidance from CTU, bring it on. I want it, and I want to make the changes that we need to make. But those listening centers were for people to develop their questions and to ask the executive team, not the governance team, but the executive teams, specific questions on the revenue cycle, on, you know, what's the reality of the layoffs? What's the situation? Why did we lose our primary care providers? So all of that was out and aired in those listening centers. And then we were able to get some responses from the cabinet members. And then there's going to be follow-up for that. For me as a governance member, attending all those sessions, I have my own thoughts and feelings that I want to share with governance. And then I want us to strategically plan to be able to move forward. We need this system, and we need people who can make good decisions. Compensations in the healthcare world, as far as I know, and it's not my bailiwick, honestly, I'm an educator, so my hourly rate was less than my top teacher. Anyway, there needs to be, I lost my train of thought there for a minute. Compensation, there is a committee, and you will hear more from that from another colleague who's going to testify that. I was not involved with compensation committee. I was on governance committee where we recruited new board members. And there is a process for that, and it's highly regulated. And again, it's not like you're giving a salary up front. There are specific goals that have to be met at a certain level for somebody to be compensated. So you have to know the whole package. It's more complicated than I can explain it to you, but somebody may.
Thank you.
Senator Long.
Thank you, Mr. Chairman. Thank you, Representative, and thank you for serving on that board. I'm sure it's a tough
Thank you, Senator.
it's a tough job. With respect to, you had mentioned staffing shortages. Has there been a lot of substantial layoffs when you were on the board?
Here's what I know based on my answers at the listening center and what I was informed as a board member. I can tell you this. The rumor mill was over 150. The last data that I have, which came out at the listening centers that Senator Rochford was at, was that there were 72 positions. Some of those were already vacant, had never been filled. 30 people were retrained in the system into other areas. One person left as a dismissal, so one firing, and 31 others chose to leave before the changes occurred. That's the information that I have. That's why I say, do a fact check.
Okay. Follow up, if I may?
Yes, sir.
Thank you. Were CEOs compensated or given a bonus after that all went down?
Not to my knowledge, not as a result of.
Okay. Do you know, follow up, if I may?
Yes.
Sorry. Do you know how long it was before they received the bonus, if they have?
I do not.
No. Okay. Very good. Thank you.
Thank you. A couple things I had. You mentioned leaders need to make good decisions. So looking at Cottage Hospital, the CEO there makes a third of what the CEO of your facility makes. Are you saying she doesn't make good decisions?
No, I'm not.
So are good decisions related to salary?
No, I'm not.
So the other thing I'm trying to reconcile is that you said that people in Pittsburgh and Stratford may die. So we saying that having a CEO or an executive wait 18 months for their bonus, people are going to die in Stratford?
If someone is not orchestrating all of the services that are provided for our people, and it's complex, I'm sure you're aware of that, it has a ripple effect. You can't have a bozo running a circus.
But you just said that the compensation does not reflect leadership, in that somebody can lead at a third of the price than what we're talking about here.
I'm not sure I follow you. I'm probably not, you probably could ask your question from somebody who is has more background.
All
than I
right,
do.
thank you.
Okay, sorry. Thank you.
Chair calls Roxy Severance. And I am going to remind the folks testifying, if you're just going to read, feel free to just summarize your points and hand in the written testimony. Sophie will make sure we get it all. We'd prefer to hear things in your own voice and summarize your points on your own. Thank you. The floor is yours. Yeah, you need to hit the red button or the gray button for the red light.
Okay, thank you. Good morning, and thank you, Chairman Rochfort, and members of the Senate Health and Human Services Committee for an opportunity to address you today. So what you have that was just passed out is about half of what I'm going to say orally, just so you know. I was thinking about that earlier. So I'm Roxy Severance. I live in Whitefield, New Hampshire. I also serve as board chair of North Country Healthcare, known as NCH, where I also sit on the Quality, Finance, and the Ethics Committees. I've served on the board since 2018 and previously chaired the board affiliate, North Country Home Health and Hospice. I am a long-time resident of Coos County. I grew up in Lancaster, was born and grew up in Lancaster, in a working-class family that relied heavily on Weeks Medical Center just 2.5 miles away. My husband and I raised 2 sons in Whitefield. As they entered college, I continued my own career to earn a bachelor's degree in human services and a master's in nonprofit management. My 30-plus career has been dedicated to improving the lives of older adults through senior housing, assisted living, memory care, and nursing home leadership, including serving as CEO of the Morrison, a nonprofit nursing home in Whitefield. Today at 70, I'm still work as president RS Consulting, supporting care for older adults. I also serve on multiple nonprofit boards, including I am the governor's appointee to the New Hampshire Commission on Aging, and importantly, I am a patient of North Country Healthcare. I know and I cherish the North Country. My lived experience and professional work has given me deep insight to the challenges of delivering healthcare in a rural New Hampshire. I joined the NCH board so I could ensure that local voices guide
guide healthcare and the needs of North Country residents, and that remains at the heart of all of our decisions. I'm here today on behalf of myself, my board colleagues, and to express strong opposition for Senate Bill 664-FN. I believe that local nonprofit boards must retain local authority, and I understand that Coos County is a distressed area. However, in Coos County, we deserve the best possible health care that you can get below the notch as well. And I want to make that clear. Local nonprofit boards must retain local authority so that we can ensure that we get the highest level of health care possible in the North Country. Our board takes its fiduciary responsibilities very seriously. We review system leadership, compensation, strategy, performance metrics, financial oversight, and care very carefully and consistently. Executive compensation, which I think one of you had asked, is determined through the work of an independent firm specializing in nonprofit healthcare compensation. They benchmark us against similar systems, and our leadership compensation is set using measurable performance criteria. And so, Senator Rochefort, you mentioned about the Cottage CEO making about a third. So she operates one hospital. We operate 3 hospitals and a home health agency. It may surprise you that surprise the committee that the NCH's CEO is compensated only at the 50th percentile among peers, and many are below New Hampshire hospital CEOs, despite leading an entire rural healthcare system with multiple hospitals and unique challenges, not just a single facility, as I mentioned. So Senate Bill 664 implies that legislators may know better than local boards about what our system needs. I don't believe that's the case. This bill imposes a government knows best model that feels like it really undermines the thoughtful, evidence-based governance work that we do every day. Senate Bill 664 would impair our ability to recruit people, to retain people, and hurts responsible management. The bill's definition of workforce reduction, 10 people within a single department, it feels like it's arbitrary and disconnected from the operational realities of running a modern healthcare system. I feel it would punish NCH for making small, responsible, and proactive adjustments needed to maintain long-term financial stabilities. Reduction in workforce, when they occur, are always a last resort. Even then, NCH works really hard, and you heard Corinne say that, works really hard to place affected employees in other positions within the system. There's still a healthcare shortage out there. We strive to train people to do other jobs within our hospitals. In healthcare, these adjustments are often about realigning resources, and it's not about economic distress of the business. Rural healthcare systems must be nimble and flexible and adapt quickly, limiting the ability of nonprofit boards to make operational decisions that will create delays and impede efficiency and make it significantly harder for us to retain and recruit leaders. Attracting top talent to Coos County already requires exceptional skill and intentional effort. We compete with large systems in Southern New Hampshire, Boston, and beyond. Adding new regulatory burdens will only make our jobs harder. I believe that this bill puts rural health care and Coos County at risk. We are in a nationwide crisis as a result, and you know that New Hampshire was awarded $201 million in federal rural health care transformation funds. Those funds are key to fixing the rural health care problems that exist. Eligibility to receive these funds require organizations to be adaptive, creative, innovative, and efficient. This bill would put us at a distinct disadvantage for competing to those grants. NCH operates 3 critical access hospitals, and we're one of the few systems in the state posting a positive margin. That stability is a product of strong, skilled leadership that we stand to lose if legislation undermines our system governance and our organizational flexibility. NCH is the largest employer in Coos County with more than 1,100 well-compensated employees whose work both fulfills our mission and supports our region's economy. If NCH were weakened, the consequences would would extend far beyond healthcare, affecting employment, economic viability, and the ability to attract new business to North Country. And I'm sure you already know that local businesses looking to relocate consistently ask, what does the healthcare system look like? People want to know that we have a good healthcare system. I believe the bill restricts innovation and sends the wrong message to new businesses. In conclusion, every single decision our board makes affects the people we know. It affects our families, our friends, our neighbors, and our employees that care for them. We do not take this responsibility lightly. For all these reasons, I respectfully urge you to vote no on SB 64 and partner with us to strengthen rural health care. I believe together we can continue to fulfill NCH's mission to improve lives by assuring consistently excellent integrated health care. And thank you for your time, and I'm happy to answer any questions.
Thank you very much. Are there any questions of the committee? Senator Long?
Thank you, Mr. Chairman. Thank you for your testimony. And if this became law, could you recall the last 3 years if NCH would have been affected, that there were 10 people that were laid off, and within 18 months, the CEO received a salary increase?
Well, my understanding is that we were outsourcing our revenue department. And so there was, I believe, about 60 people scheduled to be laid off. In fact, one was laid off. So the potential was there, right? And so we made that decision because we needed to have experts help us collect revenue.
Right, so, follow up if I may. So in that 60 people got laid off, within a year and a half, the CEO received a increase in salary or a bonus?
I don't understand the question.
Well, the question, this bill addresses the CEO receiving a bonus or a salary increase 18 months after a layoff. So the
For
60,
18 months.
yeah,
So, I mean, again, the people were not laid off, to be sure, but if it had happened, right, it could have happened. And so having the CEO not be able to receive compensation or get raises would be difficult to attract people going forward.
Okay.
Right? So that CEO may stay, and then when he retires, which he probably will, then bringing someone in and they see that bill and they think, oh, my salary is going to be hamstringed. When the CEO made that decision because it was best for the health of the organization. And the board knew about that. And the board, heard about it for months that this was coming. And we made it, and we agreed with the decision that we needed to collect revenue. Right? The senator says we are in a distressed area. That means we really need to watch the revenue and make sure that we get it all coming in so we continue the great service that we're doing and pay our executives well.
Great. Thank you.
Thank you for the question.
Senator Everard?
Thank you. Thank you for your testimony. You said there weren't any layoffs, or I thought I heard you just say there weren't any layoffs?
Well, there's a department. So 30 people chose to self-select to leave before a layoff came. 30 people were rehomed, had a job within the facility, and one person was let go.
Right. One follow-up?
Yes.
This will be my phone one. So it is my understanding that you brought up revenues and collecting.
Brought up what?
You brought up revenues?
Yes.
And one of the situations that you're running to up north is collecting, and you're getting denied on a huge basis. Somebody makes a claim, Medicaid or Medicare, whatever, and it gets denied. So there's a delay in the payment, and that's affecting your operating facility. Can you elaborate a little bit on that?
I'm not
We
sure.
were talking, well, the hospitals up there, they're struggling because of payment delays. Is that
Right, like
correct?
they mentioned about the change healthcare, right? Is that what you're referring to?
Yes.
Okay.
And so that's affecting your bottom line, and that's also trickling down to the employees as well?
Yes, but the employees still receive their wages. Is that what you're asking? During that time, we have reserves like a good business would.
Right. Well, no, what I'm asking is one, it's another situation that is hurting the hospitals up there is the fact of the non-payments on denied claims. Is that correct?
Are you talking about change or are you talking in general?
In general?
In general, yes, it does hurt our organization when we cannot collect claims, which is why we outsourced that department.
That's what I was getting at. Thank you.
Okay,
Yeah, thank you.
thank you.
Any further questions? Thank you very much.
Thank you very much for your time. I appreciate it. Do I shut this light off?
Yes.
Okay.
Chair calls Greg Placey. Thank you very much. I would ask that, if you're just going to read, just leave your comments with us. Otherwise you can just summarize the salient points,
I'll
please.
summarize this.
Thank you.
I'll summarize as best I can. The handout that I'm giving includes, besides my testimony, it includes 3 letters of opposition from 3 of the EMS organizations in northern New Hampshire. One being 45th Parallel, which is another unique organization within the state and probably within the country as well. Good morning, Chairman Rochford and members of the committee. I'm here to speak against. My name is Greg Placey. I am the North Country Healthcare past board chair. I was born in Colebrook, raised in Colebrook, spent a few years in Concord, transferred back to Colebrook. Have been involved for 12 years, Upper Connecticut Valley Hospital board, and then nearly 12 years on this board, right from inception. And prior to the inception, I was one of the members that put the organization together. During my time as UCVH chair, we reached out because we knew we would no longer exist if we didn't affiliate and become involved with others. This bill is going to hurt the future of our hospitals and our care because it's going to become more difficult to hire qualified personnel to work for us if they know this bill exists, because it'll hamstring them and won't allow them to do the job that they came to us to do, which is to continue to operate three critical access hospitals under one roof of leadership. Our coordinating together has helped us a big deal, and without the help of really expert leaders, we wouldn't be where we're at today. There would probably be at least one hospital gone. And that may also carry the home health service along with it, because we are there to support them as much as they are there to support us. We need each other to function. The people in northern New Hampshire need our health care. I was a provider, EMT from 1974 to 2011. During that time period, I can tell you there are some very sick people in northern New Hampshire. And a transfer to Dartmouth to carry someone takes a long time. We need facilities a lot closer to home to be able to take care of care. We would have had people die had they not stopped at UCVH, AVH, or Weeks prior to their transfer to more critical acts, to a more critical care. It's an important area. This bill is only targeting our hospital system, North Country Healthcare, in a depressed area where healthcare is most needed. It targets 3 hospitals. It restricts executive flexibility to make decisions and move forward and help us remain viable, healthy, qualified healthcares. It creates the presumption that rural hospital boards can't be trusted to govern and maintain and keep our hospitals where they are. We are there to govern, we are there to observe, to help things out, and keep the best possible system of healthcare in the North Country. And so I maybe missed some things that were on my report, but I hope I covered it well.
Thank you. Are there any questions for Mr. Placey? Senator Long.
Thank you, Mr. Chairman. Thank you for your testimony. As you served on the board, was there times that the entity that you hired to see what workers are owed, there was a private entity from another person that testified that hires to check and see what CEOs should be earning in a specific hospital. Was there at any time that a layoff, you needed money that you didn't have revenue, and there was a layoff to create that revenue and give some compensation to the CEO?
We have never done that. We have never had a layoff specific. We have never done a layoff that I'm aware of that was done due to the need for finances.
Okay, great. Thank you.
Any other questions? Thank you very much.
Thank you.
Chair calls Mark Kelly.
Good morning, and thank you. My name is Mark Kelly. Chairman Rochford and committee members, thank you for this opportunity to speak to you today. I've served on the board of North Country Health, first as chairman in 2016 to 2019, and continued as a board member until my term expired this past January. Prior to that, I was on the Androscoggin Valley Hospital Board for 25 years, serving as chairman the last 5 years of that term. When not volunteering my time to support healthcare in northern New Hampshire, I own a small business in Berlin that employs over 60 people. I'm here today not only as a longtime board member, but also as a lifetime resident of Coos County, currently living in Randolph, New Hampshire. Today, I would like to ask you that you vote this bill inexpedient to legislate. The bill supplants government judgment for the experience of local members of the board of directors in an area that is already highly regulated by the IRS. Senate Bill 664 would undermine, not strengthen, responsible governance. I want to use my time today to talk about the rigorous process which NCH uses in place, which has it in place to set executive compensation. To be clear, this is not unique to our hospital. This is a process that complies with the IRS regulations. Nonprofit hospitals, as well as other nonprofit entities across the state and the country, have similar procedures in place. It is the responsibility of the board of directors to ensure executive compensation is lawful, reasonable, mission-aligned, and consistent with nonprofit governance standards. Executive compensation at NCH is not discretionary, nor is it management-driven. It is governed by the NCH Executive Compensation Philosophy Statement as adopted by the NCH Board. The board delegates the executive compensation due diligence process to the Board of Directors Compensation Committee. This committee is comprised of board members from NCH and our affiliates. Each year, the committee works throughout the year to establish the NCH CEO's salary and to review the salaries of other executives. When the committee completes its due diligence, we report our findings to the recommendations to the full board for review, discussion, and decision. To be clear, the CEO does not set his own pay. The CEO does not negotiate his salary. We, the board, made up primarily of local leaders, with a stake in ensuring the continuity of our local-led healthcare system sets the CEO's salary. This is based on nationwide data, and we review the salaries of the rest of the executive team for compliance with this policy. NCH executive salaries must meet 3 objectives. First, align with the NCH mission and strategic goals. Second, compensation is reasonable and comparable to similar situations of nonprofit hospitals. Third, compensation that is competitive enough to recruit and retain qualified leaders. The NCH executive compensation policy uses national, regional, and local survey data gathered by independent firms to evaluate comparable nonprofit hospital positions. Compensation is evaluated on a total compensation basis, which includes salary, benefits, and variable pay. NCH maintains clear guardrails to ensure executive compensation remains appropriate, competitive, and compliant with regulatory expectations. Base salary is targeted at the 50th percentile for peer group organizations, while maximum total compensation opportunity is structured to approximately 75th percentile. The compensation arrangements are reviewed annually to ensure continued alignment with market conditions and organizational performance. To support this process, NCH retains Sullivan Cotter as the independent third-party compensation expert selected by the board. Sullivan Cotter provides comprehensive support, including market trend analysis, reasonableness assessment, peer benchmarking, and both written and verbal recommendations to inform our compensation decisions. The Compensation Committee evaluates the date, the federal regulation guardrails, and our policies. We then report out to the full board, who votes to set the CEO salary and review the salary of the rest of the executive team. Taken together, this structure is specifically and comprehensively designed to meet IRS intermediate sanctions, standards, and nonprofit government best practices. Senate Bill 664 assumes a governance failure that does not exist. This bill would impose an automatic statutory freeze on executive compensation if a hospital in Coos County restructures a department, regardless of whether the compensation is already market appropriate. It ignores that the board has followed an independent, compliant process, and compensation is tied to performance objectives. The bill replaces fiduciary governments with legislative wage control targeted at only 3 hospitals. Senate Bill 664 interferes with crisis leadership retention. The executives affected include those responsible for keeping our North Country hospitals financially viable, maintaining regulatory compliance, overseeing patient safety, and managing emergency response capacity. During financial stress, retaining experienced leadership is most critical, yet SB 664 would prohibit retention tools precisely when they are most needed. Senate Bill 664 does not create accountability, it substitutes rigid statutory limitations set on only 3 hospitals for a robust governance framework that is already in place and functioning. Rural hospitals require strong, experienced leadership to survive. Undermining the ability to recruit and retain that leadership increases the risk of service loss and closure in the communities that have no alternatives. I respectfully urge that Senate Bill 664 be found inexpedient to legislate. Thank you for your consideration.
Thank you very much. Question from Senator Abard.
Thank you, and thank you for your testimony. Can you just remind me how this targets just 3 hospitals?
The legislation is only set for Coos County hospitals, which are Androscoggin Valley Hospital, Weeks Hospital, and Upper Connecticut Valley Hospital. So that's 3 hospitals out of 13 critical access hospitals.
Any further questions? Senator Prentice?
Thank you, Chair Rochford, and thank you, Mr. Kelly, for taking my question. You referred to crisis leadership retention? Was that the?
Yes, I mean, going through a very difficult time, if the CEO sees that he cannot lay off to restructure a department, it may be his choice to leave. And then trying to recruit a new person to replace that person, the hands are tied because they would see this clause in their contract that says you can't lay anybody off.
Follow up?
Yes.
So so it's not that you can't lay anybody off, but if you did, there would be a freeze in compensation, including bonuses, et cetera, correct?
Correct.
Okay. So is it your position, even though this does not reflect like a base salary negotiation, but a possibility that could take place, that this will impact the ability to recruit people because they see this 18-month period as untenable?
Well, if you're recruiting somebody and you have to look at a total package, which I mentioned is not only just
Right.
salary,
It's benefits.
but the key thing is a bonus if you meet your guidelines. If one of the guidelines is I have to restructure this department, and that might mean some layoffs, but I don't get a bonus for that, but my objective is to keep the hospital or the group of hospitals, 3 hospitals, operating, we may have to make that. And trying to recruit, and I've been involved in recruiting 5 different leaders over the last 35 years that I've been involved in hospital administration. But putting something like that or referring to a state clause that says you can't do this yet, we have to tie your hands. You won't get a bonus if you lay off people. That's kind of a no starter for many people if we're doing, and we've recruited nationally when we've tried to bring people in.
Okay. Thank you very much.
Any further questions? Seeing none, thank you very much.
Thank you.
Chair calls Don Crane. I didn't see you back there, Don. I was looking for you. You're hiding.
I figured it out. Thank you, Mr. Chairman and members of the committee. I appreciate the opportunity to speak with you today, and I will keep this mercifully brief. My name's Donald Crane. I've lived in Littleton the last 2 years and previously lived in Lancaster for 33 years. I recently retired after 45 years as a CPA, or 35 of which were spent in the North Country. I've served on the North Country Healthcare Board since the affiliation was formed, including 2 years as the chair of the board, and in leadership roles on the Finance, Compensation, and Quality Oversight Committee. And I'm currently chair of the Compensation Committee, which I've been on since inception. Before that time, I was a trustee at Weeks Medical Center, also served as board chair there. So you've heard from several of my fellow board members about governance and recruitment and workforce impact and the operational consequences of this bill. I'm not going to repeat their analyses, but I do want to focus on what's really at stake. This bill is not simply about executive compensation. It's about whether locally governed rural hospitals will retain the authority to make responsible strategic and operational decisions necessary to survive. North Country Healthcare is the healthcare safety net for Coos County. It comprises 3 critical access hospitals and a home health and hospice agency serving some of the oldest, sickest, and most economically challenged residents in New Hampshire. We employ 1,100 people in a region already facing economic hardship. Our 3 emergency departments operate around the clock in communities where the next hospital may be more than an hour away. Rural healthcare nationwide is in crisis, as you've heard. Hospitals are closing, services are shrinking, recruitment is increasingly difficult. Stability in this environment requires strong governance and experienced executive leadership, not an additional statute that constrains our ability to respond to the best operational practices appropriate. You've heard from several testifiers that executive compensation at NCH is governed by federal tax law and overseen by independent board members. The board, not management, sets compensation. It's benchmarked, market-based, and tied to performance. Workforce reductions, when necessary, are approached cautiously and as a last resort. This bill assumes a governance failure that does not exist. It replaces a functioning, accountable board structure with a rigid statutory mechanism, and it singles out, as you know, the three hospitals in Coos County, leaving the rest of the state untouched. If enacted, this bill would undermine recruitment and retention of qualified leadership, restrict flexibility at a time when rural hospitals need it most, and introduce uncertainty into long-term planning. The consequences would not be abstract. They could mean delayed care, longer ambulance transports, lost jobs, and an increased risk of service reduction. Or worse, as board members, we're volunteers. We live in these communities. Our families receive care at these hospitals. Our neighbors work there, and we understand our fiduciary responsibilities and the gravity of the decisions we make. We also recognize that communication around recent decisions should have been better. And that's both management and the board have acknowledged that. Our leaders are engaging more directly with the community and making every effort to strengthen transparency. But improving communication is not the same as surrendering governance authority. Rural hospitals face existential challenges driven by demographic trends and persistent financial pressures, including declining reimbursements from federal programs and insurers. Adding further statutory constraints will not solve those problems. It will make them harder to manage. We seek instead to work in partnership with the legislature to strengthen the sustainability of our organization, support workforce development, and protect access to care in the North Country. So on behalf of our patients, employees, and communities, I respectfully urge this committee to find SB 664 inexpedient to legislate. Thank you very much for hearing my testimony, and I'd be delighted to make an effort to answer any questions that you have.
Thank you very much. Any questions from the committee? Thank you very much. That's the last I have signed up. Is there anyone else that'd like to speak on Senate Bill 664? With that, I'm going to close the hearing.
right, we're going to open up the hearing to SB 670 FNA. We're here from the prime sponsor.
Thank you very much. For the record, my name is David Rochefort. I represent Senate District 1. Before we have Senate Bill 670, establishing a Developmental Services Oversight Commission relative to membership and duties of the Incapacitated and Vulnerable Adult Fatality Review Committee, and those issues around founded reports of abuse, neglect, or exploitation of vulnerable adults. So this bill came about as a result of a rather shocking expose of our developmentally disabled community and care and treatment that's going on in that. I think we're all familiar with the three-part series that came out in the fall that really highlighted some areas of concern where we need to increase and boost our oversight of this committee, as we know, or this community. As we know, this is a very vulnerable community. Some of the most vulnerable people that are living amongst us. And it's the state's responsibility and duty to ensure that not only they're getting care, but if that care is lacking, there's accountability for that. And so I know we've got the bill before you. It's rather long, but briefly, it focuses to strengthen the Developmental Services Oversight Commission and allowing or clarifying the positions and criteria that make up that commission. And this was developed in conjunction with members of Health and Human Services, the Disability Rights community. I know the majority leader, the Senate president, was in on those discussions, and we spent time really looking at what can we do now. We talked about perhaps taking what we found that was exposed in that article and waiting, and I think we all kind of got around the table and realized there's things we can do now. This is a late bill that we can do today that would ultimately strengthen that oversight and provide better reporting of these instances so that the state can act and take appropriate response to that. We did draft the bill. There were some things that were overlooked. You have an amendment in front of you as well, so I hope that it's the committee's will to pass the bill, but also pass the amendment 0782, which clarifies some things that were missed in the first draft. So the bill's before you. I know we have a number of folks signed up to speak, and with that, I'll give the committee the bill.
Questions from the committee? Seeing none, thank you, Senator. Just want to remind everybody there's a single person in opposition, so if you limit your comments, it helps us help you. And could I call up Chris Bond and Jen Duval? And then we turn over the chair.
Oh, they do. And I'm not actually going to give you the option of limiting your comments. So we're going to have a timer for 2 minutes here. So if you have written comments, feel free to submit those. But given the time constraints that we have in the committee, we're going to be imposing a timer of 2 minutes. So thank you.
I think he said except for you. Right?
Who do we got?
For the Department of Justice.
Yes, the department, of course, you can have your time.
Oh, thank you. Yeah, that'll spare me talking very, very fast.
It's just unfamiliar faces in front of me. You don't usually come before us. Yeah, I see Henry Lippman here every day, and you're not Henry, so.
Understood. Thank you. Thank you, Senator. Thank you for the committee. It's my pleasure to be here. I'm Chris Bond, for the record, Chris Bond, Associate Attorney General. I'm the General Counsel at the Department of Justice. I have with me Dr. Jenny Duval, who is the state's chief medical examiner. So I do want to say, first of all, of course, the Department of Justice absolutely shares the goal of preventing avoidable deaths and improving oversight in the developmental services and vulnerable adult systems. But that said, we do have some concerns about the way in which the bill is drafted, specifically with respect to the definitions of incapacitated and vulnerable, which
already existed in the extant legislation, but those get pulled into new obligations that are put on the Office of the Chief Medical Examiner. And because those definitions are understandably very broad.
I'm going to interrupt you. Do you have the amendment?
I did not, I had them emailed to me just when I was out in the hall. I have not had
Okay,
a
all
chance to
right.
look at those.
Because I know those, the vulnerable adult definition has been updated, so I don't know if that would affect your testimony.
It's possible. I'll have to take a look at that. And I can certainly circle up with the committee afterwards. But as the original draft was written, given the extent, oh, thank you. Okay, thanks. I will take a look at that. The broad definitions of incapacitated and vulnerable, coupled with the obligation on the chief medical examiner to report such deaths to the incapacitated and vulnerable adult fatality review committee, our understanding between the chief medical examiner's office and the DOJ is that that would sweep in the vast majority of all adult deaths. And I respectfully don't think that's the intention of the committee to sweep that many in. So we would be interested in seeing some changes. And again, I'll have to absorb this amendment and see if maybe that addresses some of it. But as written, this would be a significant additional resource burden on the department. It would require additional attorneys, and we've put in a fiscal note, it would require additional attorneys and additional staff. We would be very interested, though, in working on changes that would not sweep in deaths where there was not going to be a lot of opportunity to kind of weed out the problematic systematic issues. So with that said, I'm happy to yield to questions, and Dr. Duvall could answer any questions about sort of the role that the medical officer, the chief medical examiner's office has in this review. And she is, just for clarification, she is also, as the chief medical examiner, a member of the incapacitated and vulnerable adult fatality review committee.
Did you want to comment or?
Yeah, just so you can understand the volume that we're speaking about, there were approximately 4,500 adult deaths that were reported to the Office of Chief Medical Examiner last year. So we're talking a dozen a day, every day, Saturday, Sunday, holidays, that would be required to be reported to the Attorney General's office and the committee to determine if these are preventable deaths in vulnerable adults. So that's my concern, is it would just overwhelm us.
And that wasn't the intent, is to sweep up every death. So what I would ask you to do, if you can look at the amendment, if that addresses the concerns, and submit back to me, any thoughts or insight, because that wasn't the intent there, and we know how some of these things go in drafting. So if you could take a look at the amendment and see if that changes, your insight on that. And if not, submit any suggestions for an amendment back on that, would be great. Yeah, we're under a time crunch here, but
Sure.
2 weeks. So
2 weeks, okay.
if you can get it to me in a week, that would get us the ability to send it to drafting. And
Okay, yeah, absolutely. We'll take a look and share our thoughts on that. And I think it's possible that in addition to tweaks to the definitions, which may already be in here, we might have thoughts about the appropriate role of the chief medical examiner's office and whether and I think just fundamentally, I think there's sort of a tension here between should additional resources be going more to a law enforcement side or more to a sort of system review side. And so we may have additional kind of thoughts in that vein, but we'll certainly take a look at the amendment and let you know our thoughts.
Absolutely. Open to any input you can provide.
Appreciate that. Thank you very much.
Great, thank you.
Are there any further questions from the committee? No, thank you very much. So again, reminder that we will be timing comments, and another reminder that we have everyone signed up is in favor of this. So that probably will help your case. Isadora Rodriguez Legend.
Good morning, Chairman and members of the committee. My name is Isadora Rodriguez Legendre, and I serve as the Executive Director of the New Hampshire Council on Developmental Disabilities. I do have written testimony, so I am just going to try to summarize some of the most important points and also some information that I'm sure you'll hear from others with lived experience regarding this matter. The first thing I want to say is that the systems and the policies that have been in place up until this point are evidently not enough to support people in the community and ensure their well-being and their safety. And so we are in support, our organization is in support of establishing a commission, one with more teeth, one where legislators can serve and in real time talk about improving the laws and the systems in place to make sure that vulnerable adults, people with intellectual and developmental disabilities especially, are protected and are integrated into their community without fear of abuse, neglect, and exploitation. The other thing that I would like to say is that it is important to have access to data. And that is something that I believe that other systems are lacking. And so I think that this bill calls for and strengthens the ability for a body to access real-time data from the system that is intended to support individuals. And again, that can be used to make sure that this sort of thing doesn't happen again.
And do you have have you submitted your written testimony?
I have.
We got it? Okay, that was what
So
was
one more point,
circulated.
I just want to make it that we are not listed as a member, and because we are federally mandated to address the needs of individuals with intellectual and developmental disabilities, I don't know if we're in the amendment, but I would recommend that the New Hampshire Council on Developmental Disabilities be added to the membership body of the Oversight Committee.
Great, thank you very much. Are there any questions from the committee?
Real
Senator
quick, yeah, you said access to data. What kind of data?
So it's data about deaths, about abuse, data related to how different agencies are ensuring things like criminal background checks and responses to reports of abuse and neglect. And so those are things that I'm a state agency and I don't have access to those things.
Thank you.
Thank you. Any other questions? No, thank you very much.
Thank you.
Chair calls Louis Esposito.
What a great name. Oh. You didn't have to say that.
Yeah, the gray button there.
That would
Thank
help.
you.
Thank you, Honorable Chair and members of the committee. My name is Louis Esposito. I live in Hollis, New Hampshire, and I serve as the Executive Director of ABLE New Hampshire. Previously, I worked with students with intellectual and developmental disabilities at a high school and also supported adults in community-based programs at a private provider. During my life, I've had the opportunity to support hundreds of people with disabilities all throughout Southern New Hampshire. While neglect and abuse might not have been on the forefront of many individuals particularly, I promise you this, a lot of families, moms and dads, it was the front of their minds throughout all of my work with them. What is clear, after the reports came out from the New Hampshire Bulletin, families had a lot of issues with trust within the developmental disability system. And the trust, whatever's left, has been very, I'm not sure how much is there anymore. It hurts a lot of people. It hurts a lot of families, and this is something that we need to repair. I want to mention a student of mine, an old student of mine. She was vibrant, energetic, and I promise you, she would light up the room. She would give you a big hug. She was one of the best people I've ever met. When she was angry, you would know it. She would hit, bite, kick. I had scars. I had bruises on from working with her. But one of the things I want to emphasize was she doesn't have the ability to necessarily call up a phone number to report the neglect and abuse. The behaviors that she had were her way of communicating. And despite her working for many years being supported, these behaviors came out in different ways. And, one of the things I really want to make sure that you all understand is it's not necessarily going to always be, easy to find somebody that's being abused. There's a lot of subtle signs out there. And it really worries me because I don't know where the student ended up. But when I read these articles, she was the first thing on my mind because she couldn't just say it to anybody. It would come out in these behaviors, which might result in more neglect and abuse over a period of time. So I know I'm running out of time. I know all the Esposito, Phil talk, but I've had a lot of opportunities and experiences supporting many people in the system, direct support professionals too. We're all hurting. And I think we need to really start looking at the accountability of the system and making sure that we build the trust back up for a lot of families.
Great, thank you. Are there any questions? Senator Hebert.
One question. Trust.
Yeah.
Give me an example of how trust is being broken.
People died. So when I'm meeting with families, especially when I was meeting with families when I was transitioning students, one of their biggest fears consistently is what's going to happen to my son or daughter when I pass away. And you're putting that trust in the hands of somebody you might not really know, a direct support professional, which oftentimes could be undertrained, overwhelmed, and not really paid that well. And turnover is really high. And there's a significant lack of, significant need of direct support professionals throughout the field. And you're putting that trust in community programming and residential programming. A lot of families, when you leave the school system, you enter the adult system. It's a new world. The schools are this kind of consolidated, like everyone's tight knit. You know who your representatives are. Yeah. A lot of parents, have the same case manager, especially in this population of people with disabilities, from 14, 15 years old until the day they turn 22. That's 8 years in a row with the same school system, right? You're protected. You might have disagreements, but I feel like you get to know them. Then all of a sudden, this big open world kind of hits. You're out in the community. You're no longer in the classroom. You are working. You might be looking at moving in with a roommate or in a residential type placement or by yourself. And you're trusting people, consistently. And, and it would really hurt seeing some of these stories because, those families trusted the staff. They trusted the service providers and they trusted everybody. And I'm not saying that everybody's like that. I know there are a lot of DSPs and service coordinators that are really hurting right now reading these articles and they want change too. But, we need to repair that and it's the right thing to do. And I think, this is a step in the right direction. Thank you.
Thank you. Any other questions? No, seeing none, thank you very much. Chair calls Martha Hickey.
Good morning. My name is Martha Hickey, and I have a son with autism. And I am here, and I could not have followed two better people. It will expedite my testimony exponentially. That our son, who is living with autism, expressed to us, and he's nonverbal, his desire to live more independently. While very apprehensive because we were a self-directed model, because we controlled who we hired, how they were trained. I was supervisor, and in the event, I was also a person that would terminate that support. Trust is of the utmost basic necessity. As a parent, handing over our loved one to the care of someone else. We did our due diligence in our mind and placed our son in a farm-like environment because of his love for animals. We did a slow transition gave them plenty of time. It was months. You'd have a date, move-in date, it got pushed. Another move-in date, it got pushed. Understood? You do what needs to be done so you're ready for our son. His behaviors, his medications, his documents, everything. We supplied open book, cards on the table. Nothing to hide because we want our son to be successful. He moved in and within less than 48 hours, I was called to a meeting in the nurse's office and asked to bring him home. Someone had anonymously called and filed a report with DHHS on Billy's behalf. Spent the summer working with investigators from the state, and it was founded that this institution, this facility, was negligent of the care of the person and of his medications. When moving him out, I found 2 of his seizure medications underneath his recliner. And upon the investigators' search of his apartment, there was another unidentified pill under the refrigerator. Billy came home with escalated behaviors. It took us over 2 months to get him back to baseline. He was aggressive, he was agitated, and it was me and one other person, and my husband, taking care of him. It was a very small and well-educated team that needed to bring him back to baseline, which did happen, thank God, in July. That was from May, June, July. Beginning of August, we felt like he was at baseline. That's how long it took for Billy to feel like he could trust his own parents again. He did not have a seizure, even though he missed the medications that I did find. My concern today, and it is my hope with the passage of this bill, and thank you so much for putting it forth, is that all of the departments at the state, I think, were probably, mostly, hopefully, constructed in a way to address an issue. However,
And I hate to interrupt you, but your 2 minutes are up and we've got to wrap it up here.
So my hope is that these silos with this committee start talking to each other. The investigation, the report never went any further than the office of the investigators.
Thank you. Any questions? Hopefully we can address that with this. Thank you very much. Karen Rosenberg.
Good morning, Chairman Rochford and members of the committee. I'm Karen Rosenberg. I'm the Policy Director at the Disability Rights Center. I'm here to testify in support of this bill and answer any questions that you might have regarding it. I want to thank you, especially Senator Rochford and Senator Bertzel, for spending so much time working to develop this legislation, which would be an important start to addressing some of the lack of oversight and atrocities that were exposed over the early fall by the Bulletin's articles. Our office was involved in developing several sections of this bill, in particular the portions it's beginning at Section 3, which involves strengthening the Incapacitated and Adult Fatality Review Committee. This is a committee that was set up to look at fatalities involving incapacitated and vulnerable adults in a very safe space so that it operates highly confidentially. And the purpose is to examine deaths and make recommendations for how those deaths may be prevented in the future and whether there are any systems that need to be addressed. And a member of my office sits on that committee. There's Vanessa Blaze, who's here, can answer any questions you have specifically about that committee. But the idea with this amendment was to ensure that the committee receives the referrals that they need, the cases they need to examine. I understand there's some concerns that it may be too broad, and so our office, I've already been speaking with the Attorney General's office about what might be some language that would hone the list so that they're not looking at 4,500 deaths, that 4,500 deaths don't get referred to this committee. Unfortunately, Senator Rochford, I don't think that the amendment really truly addresses that. So I'm hoping that there'll be a little time. We have a meeting scheduled for tomorrow. I'm hoping we'll be able to get some language to you.
You got a week.
A week. Well, we're gonna try to be ahead of that schedule. Do you want me to talk about the rest of that we worked on?
Wrap it up very, very quickly because we.
The remaining portions of the bill that we worked on were to strengthen the reporting of incidents involving serious bodily injury or death of people who receive services, state-funded residential services. And the idea is to try to work on closing silos and make sure that those cases get the attention that they need. So it would expand reporting of those kinds of incidences, not just to like Adult Protective Services and the Office of Client and Legal Services, but also to the Licensing and Certification Bureau, to the Attorney General's office, and to our office. As the state's protection and advocacy system, we are authorized to investigate alleged abuse and neglect in the system. And so our hope is that by broadening the referrals of such instances to our office, that there'll be more, and these other offices, that there'll be greater oversight. And again, it's about prevention. It's about identifying.
I would just ask you, and again, I hate to be rude, but we're going to lose this room here shortly.
Okay.
So
That's all I've got.
I just make sure you connect with the Attorney General's office and get something back within a week, and we can go from there. Thank you.
We're on it. Thank you all so
right.
much.
Andrew Horn.
We're losing the room.
Hello, honorable members. We cannot escape history. Future generations will judge us by what we do here today. We have seen the darkness in our disability care system, exposed by the three-part investigation published late last year by the New Hampshire Bulletin, which revealed systematic abuse, neglect, and death. These are not just cases. These are people. They are our neighbors, and they deserved better. I urge you to recommend ought to pass on this bill. Additionally, I urge you to adopt the amendment that I attach to my testimony, which requires at least 2 committee members to be people with disabilities ourselves, chosen from within the agencies represented in Section 3. As someone who lives with a disability, I remind you of our principle: nothing about us without us. We cannot analyze these deaths without the voices of those who understand what it means to live with disability. Whether we touch the system or not, we know the stakes when institutional vigilance fails. This bill will ensure the next tragedy is prevented rather than repeated. A system that buries its mistakes will soon find itself buried beneath them. We have a duty to protect those who cannot protect themselves. Let us be touched by the better angels of our nature. Let us have faith that right makes might. And in that faith, let us dare to do our duty. I urge you to recommend ought to pass in this bill. I'll take any questions.
Thank you, Andrew. Are there any questions for Andrew? Thank you very much.
Thank you.
Chair calls Karen Blake.
Good morning.
Oh, you could have used his time, right? Yeah.
All done. All right. Good morning, everyone. Good morning, Chairman Rochford and members of the Senate Health and Human Services Committee. My name is Karen Blake, and I live in North Woodstock, New Hampshire. Full disclosure, I am the Director of Community Partnerships for Community Crossroads. I'm also the co-chair of Northern Human Services Family Support Advisory Council and a seated member of the Quality Council in a family support seat. All of that's great. I am not testifying on behalf of any of those organizations, just from a personal standpoint, and I will be brief. I fully support this legislation. I think it is well needed. I have a almost 19-year-old who experiences a developmental disability, and
I don't know what the future is going to hold for him. I don't know if he's going to be in a residential treatment facility. I don't know if he's going to be in adult foster care. I don't know any of that. But I do know that I won't be there to see it. I had him when I was 36 years old. My husband was 50. He's already gone. He passed away when my son was a freshman in high school. I am very concerned about the safety, not only of my loved one, but everyone's loved ones here in New Hampshire. So fully support section 3, 4, and 5. The one question that I have, I fully support, maybe, putting together a commission which works with stakeholders as well as legislators. But my question is, how is that going to work with the Developmental Disability Quality Council? We already have a very robust group that meets very regularly to talk about issues of quality and ensuring the safety as well as the good quality of life for individuals who experience disabilities here in New Hampshire. So it's not clear from the legislation, and I know that we're going to continue to work on this, but I do want to thank you, Senator Rochford, for bringing this late session bill. With some of the things that, came out in November, it's very needed. Thank you.
Thank you very much. Are there any questions? No, thank you for coming down today.
Thank you.
Chair calls Marissa Berg.
Right. Chairman Rochford, members of the committee, thank you all for your time and hearing testimony today. Oh, do you want a minute? Okay, go ahead. My name is Marissa Berg. I am here representing Community Support Network, and we are the association of the 10 area agencies in the state of New Hampshire that support people with developmental disabilities and acquired brain disorders. I am here to share CS&I's support for SB 670. I also want to highlight a possible duplication that was actually mentioned earlier, the testimony just before this, about a possible duplication of efforts between the commission that is outlined in sections 1 and 2 and the existing it's RSA 171A:33. It's the New Hampshire Developmental Disability Quality Council. We, again, fully support the proposed changes to the remainder of the bill, so section 3 and beyond. We do believe that it will do a great deal in advancing safety and quality services for people with disabilities in New Hampshire. I have shared before you copies of a letter that includes the full existing text of RSA 171A:33. This is the legislation, again, it's been in place since 2009, allowing the New Hampshire Quality Council to conduct its work. We are concerned that by having both the commission and the Quality Council occurring at the same time could create some level of confusion. You see on the letter before you, the sections starting on page 2 that are highlighted are areas where there is some pretty significant chance of duplication. So it's either a person who is whose position appears on the roster for both groups, or individuals with developmental or seats that are open to people with developmental disabilities, brain injuries, or their family members. I want to highlight that the Quality Council statute actually requires that at least 51% of membership are people with disabilities, which is really significant. Somebody mentioned earlier, nothing about us without us. And I think the Quality Council really, that legislation does include that, gives people a meaningful voice. So I also want to highlight the sections that are underlined and in bold in the letter in front of you are suggestions. I would say that if there is openness to an amendment, possibly that there also be some discussion with the Quality Council members themselves. This is simply my suggestions. But I just want to highlight that there could be some duplication there. So again, I want to thank you for your time. I recognize I'm over my time, so if there are any questions, I'm open to taking them.
All right, thank you. Are there any questions from Marissa?
Beautiful handwriting.
Oh, thank you. Thank you so much.
Notice she doesn't say that about me.
I haven't seen yours.
Chair calls Lisa Bowden.
Thank you.
Thank you. Thank you.
Good morning. For the record, my name is Lisa Bodwin. I am a disability policy professional with Strategies for Disability Equity, and I'm also a parent. I agree with most of the previous testimony, and I will submit my written testimony. I'm first day out from 5 days of being slammed by this horrible cold. I wanted to highlight that families are horrified and terrified and frustrated. But unfortunately, the articles that came out in New Hampshire Bulletin last fall are not unknown by the Bureau of Developmental Services, by the Department of Health and Human Services, and other entities. It is easy to point to direct support professionals, but the problem is that we do not have sufficient warning flags when there are issues that are happening. We don't have a rubric for accountability when it comes to the entities, whether they are our beloved nonprofit service providers or the Bureau of Developmental Services or the Bureau of Adult and Elderly Affairs. We absolutely have to have not only pattern recognition, which this bill is trying to help provide, but we also need corrective action, and we also need a rubric for accountability. Nobody in any managerial position, either within the Department of Health and Human Services or any of the provider agencies, has been held to account for the abuse and neglect documented. And that is where we need to begin. Because if we want to be able to have
I'd ask you to wrap it up, or
for years, the Quality Council has demanded data from the Department of Health and Human Services to execute its legislative mandate. And for years, there has been institutional noncompliance, and it obfuscates us from being able to execute our legislative mandate. I will submit the rest of my particular comments. Thank you so
very
much.
much.
And I do support the bill.
Thank you. Any other questions? That's the last I have signed up to speak on Senate Bill 670. Anyone else that would like to speak? With that, I'm going to close the hearing. So we're going to open the hearing on Senate Bill 665. I'm going to ask Senator Ricciardi to introduce her bill.
Thank you, Mr. Chair and members of the committee. It's so good to see all of you. I know you've had a long morning. For the record, I'm Denise Ricciardi, State Senator for District 9 from beautiful Bedford to beautiful Hinsdale. I'm here to discuss my legislation on pharmacy benefit managers, or PBMs. The legislation before you requires the disclosure of the lowest available price to consumers at the point of sale, and thus will help drive down healthcare costs for consumers. The idea for this legislation came to me after constituents raised concerns about PBM's intentional failure to disclose lower-cost drug options. In many cases, PBMs are fully aware that a consumer could pay considerably less. However, they do not inform the consumer. Most consumers never even have the chance to know about these options, nor that they can ask about them. This allows PBMs to profit from retained rebates, spread pricing, administrative fees, or steering to PBM-owned pharmacies. The lower cost options can come via several ways. One is using a coupon. 2, buying directly from a pharmacy. 3, choosing a therapeutically equivalent alternative. Or 4, paying cash instead of a copay. Put simply, the current environment promotes ambiguity. When information is withheld about lower cost options, unnecessary costs are shifted to customers. The costs are not because the medication costs more, but because more affordable alternatives are deliberately left unpresented at the point of sale. Lawmakers are not being asked to dictate drug prices. Rather, the goal is to allow for fair competition by ensuring transparency for consumers. Requiring PBMs to disclose the lowest price already available does not distort the market. What it does is it corrects an abuse of market power. To have an effective market, consumers need proper information. That is the only way they can make the best decisions for themselves and their families. I understand the committee is working very hard to tackle this issue. I'd like to look forward to working together to help protect the people of New Hampshire. And I want to mention that this helps us, the legislature, drive down healthcare costs for the Granite Staters. And that's our job. And this is a really big way that we can do that. I also want to mention, I have several examples, but in the interest of time, I'll give you one example. My constituent suffers from migraines, went to the pharmacy to get her prescription. It was 9 pills for $275. Had she known enough to ask for the rebate or coupon, she could have gotten 12 pills for $25. And so I ask this body to consider passing this legislation so we can reduce healthcare costs for our Granite Staters. And I'm happy to take any questions.
Thank you very much, Senator. Are there any questions for Senator Ricciardi? No, thank you very much.
Thank you.
And we have an amendment. No, we don't have an amendment. I'm looking at something else. All right. Yes. Chair calls Jeb Kurlop. We are under some time constraints, so we're gonna put a timer on you. Apologize.
Hurry before she starts it.
Good morning, Mr. Chair and committee members. My name is Jeb Kurlop. I'm a resident of Merrimack, New Hampshire. I'm here this morning to respectfully ask for your support of Senate Bill 665. This bill is about transparency and full disclosure and driving down healthcare costs. It will automatically ensure that prescription drug consumers are informed of existing discounts, rebates, coupons that could save them money at the pharmacy. Currently, pharmacies provide these savings opportunities only if a consumer asks, and that's the rub.
If a consumer does not know to ask this question, they risk unknowingly paying more for their medication. I would like to share a recent personal experience. In January, I went to Walgreens in Nashua to pick up a 90-day blood pressure prescription for Ezetimibe. When I arrived, the prescription was ready in a neatly bundled bag, and the price was $95.49. I asked the pharmacist, do you have any discounts, rebates, coupons available, or can I purchase it directly from the pharmacy without using my insurance? I want the absolute lowest price. After a quick look, 3 or 4 seconds, the pharmacist looked into her computer and said, yes, I can lower your cost to $35.69. That question saved me $59.80, or the equivalent of 2 days of groceries. I have the documents of this transaction if you'd like to examine them. I've been asking this question regularly and have saved a significant amount of money. The problem with the current system is that consumers must know to ask. Pharmacies are only required by law to inform customers that a lower price is available if they ask. Senate Bill 665 would automatically require pharmacies to provide the lowest available and the benefit of all available existing rebates, coupons, discounts for a prescription drug. Anyway, I want to be quick. I believe this bill, it instills honesty in our system. It gives individuals, consumers, the right to rebates, discounts that are already existing. We're not asking that any changes be made to contracts between pharmacy benefit managers, pharmacies, insurance companies, nothing at all. We're simply asking that this advantage be applied to all New Hampshire citizens. At the moment, right now, people are going into pharmacy throughout the state of New Hampshire, and they're unwittingly paying the higher price, like I just shared with you. I believe this bill, as government is looking to reduce the cost of health care, this is the mechanism. This bill is going to drive down health care costs. And we need to start. And I know you're all struggling with how are we going to reduce health care costs. This bill will reduce health care costs. I thank you very much.
Thank you very much. Are there any questions from the committee? No, thank you very much. And Jason, as is, I have you on. Did you want to speak? You did not check the speak. Okay. If there's anybody that would like to ask you a question, they can do it now, right? All right. Is there anyone else that would like to speak on Senate Bill 665? With that, I'm going to close the hearing. I got a motion and a second to move into executive session. All those in favor say aye.
Aye.
Any opposed? All right, executive session. We are in it. All right, we ready, Sophie? Okay. So I'm going to move to pass on Senate Bill 441. We got a motion and a second, and then I circulated 2 different amendments to you. One was 446 and one was 722. I'm going to actually move amendment 2026-0446. Senator Birdsall.
So which one are you?
I'm going to move amendment 446.
I'll second.
Yes, this amendment here, 446, was provided by the, what is it, New Hampshire Legal Assistance?
Yep.
They were the last speaker on the day of that. We also reached out to the Municipal Association and looking at both amendments. I know I asked the prime sponsor to get in touch with legal assistance as well. She is aware of this amendment. It's her opinion and mine that of the two that we have, Amendment 446S is the better of the two. So if there's any further discussion on that, we'll have it. If not, I'll call the question on Amendment 446. All those in favor say aye.
Aye.
Any opposed? So the motion is ought to pass as amendments by Senator Avard. Senator Birdsell seconds that. All those in favor? Yep.
Just to quickly thank you, Senator Chair Rochford, and thank you for your amendment because I think it improves the bill. I just maintain my position that municipalities already have the authority to do this. So I'm not going to support the underlying bill, but I have supported the amendment because I do believe it makes it better. Thank you.
Okay, thank you. Any further discussion? I'll call the question. All those in favor say aye. Opposed? So 3-2.
Yeah.
Yeah, so you wouldn't object to consent?
No,
would you?
I wouldn't object to consent.
So I'll move consent.
No.
And I got a second from Senator Avard. So motion is to consent. All those in favor say aye.
Okay.
Any opposed? All right, and let's see. Who do we have on that? Let's see what I've got. All right, I'm on the, you're on the bill, I'm on the amendment.
I'll take that.
Yeah. Senate Bill 455.
I'll make a motion ought to pass.
We got a motion and a second ought to pass. Senator Prentice has an amendment.
The amendment, thank you.
You want to move the amendment at this point?
So are we talking about 0637S?
Yes.
Okay, yes, I'll move the amendment.
And Senator Birdsell seconds that. And you want to speak to your amendment?
I would love to very briefly. I'm taking a belt and suspenders approach to this, that I know that the Department of Health and Human Services came in and talked about the things that they already cover, but this institutionalizes this and puts it in a position where they just, can't be cut by a policy that isn't managed by the legislature. And so that's my amendment. Thank you very much.
All right, any further discussion? So we're going to vote on the amendment. All those in favor say aye. Any opposed? So the motion is ought to pass as amended. Any further discussion? All those in favor say aye.
Aye.
Any opposed? Senator Birdsell moves consent.
Second.
Senator Prentice seconds that. All those in favor say aye.
Aye.
Any opposed? And Senator Prentice will take that out.
Yes, I will. Thank you. Let's take it out.
Kevin's going to take out the other one. So we're going to go to Senate Bill 480. We're going to skip 478 because we're still working on that, but I'm going to move ought to pass on Senate Bill 480.
I'm going to second that.
And Senator Prentice seconds that.
And we do have an amendment. The PTOT bill, the amendment is 0776S.
So Senator Prentice moves amendment 0776S. I will second that. Would you like to discuss your amendment?
Just briefly, although we'd like it to be 12, 12 visits. I believe compromise, even though we do not have universal compromise on this, is to come down to 8. We also tightened up the language, so it is specific to PT and OT services only. Okay,
480.
480, and the amendment is 0776S.
And just to clarify that, because previously it was general rehabilitative
Right, and
services,
that's
so
what-
you're narrowing it to OT and PT.
PT and OT, so respectfully, I heard from
Yep, exactly. And then it's 8 treatments rather than 12, which is what I think we originally had, was 12 treatments.
we did have 12, correct, mirroring legislation in other states.
And I think you and I spoke about this.
We did.
You did work, this is a compromise with the plans.
This is, they're not in agreement. We
Okay.
don't agree right now. This is my offer. I want to hold the line on this and
All right.
continue to work on it and see if we can even get to a better position, but
So you tell me you negotiated against yourself?
I'm trying to.
All right.
The amendment that we're voting on right now.
I'm
Yep, we're gonna
working on access to healthcare.
Call the vote on amendment 0776. All those in favor say aye.
Aye.
Any opposed? Any further move ought to pass as amended. Any further discussion?
Second?
All those in favor say aye.
Aye.
Any opposed? I'll move consent.
Second.
Senator Birdsell seconds. All those in favor say aye.
Aye.
Any opposed? Senator Prentice will take that one out.
Yes, I will. Thank you.
So 1, 2, 3. Senator Birdsell, are you ready for 498?
498.
I'll second.
Senator Birdsell moves ought to pass on Senate Bill 498. Senator Prentice seconds it. Any further discussion?
I'm happy to, Senator, Chair Rochford, if I may. I think we've come a long way with this policy. I think we have stakeholders from the state, from advocacy groups and the carriers at the table. I don't think we're I'd like to see everybody completely agree 100%, but I believe we are close. So I'm comfortable moving this forward. I fully support this and hope that all the stakeholders can wrap themselves in as well.
All right.
Can you reach?
Yes. Okay. And I have spoken with some of the stakeholders, and they want to continue this going through while they are still working on it. So,
Is this going to finance?
It is.
yes.
All right.
But that's okay. You can
Yep.
put it on consent.
So we'll call the question on 498. All those in favor say aye.
Aye.
Any opposed? So 4-1. And I'll move.
Consent.
Senator Birdsell moves consent. I'll second that. All those in favor say aye.
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 Any opposed? So Senator Birdsell will take that one out.
Yep.
Senate Bill 506. I move interim study.
I'll second the interim study.
So we've got a motion and a second on interim study. I'm going to speak to the motion real quickly. If you recall, we concurred with the House position on this. So in speaking with the prime sponsor last night, the bill isn't needed, but we'll hold it in interim study and move forward with the other bill.
Why did you say that in the beginning?
I don't know.
I'm not doing that.
All right.
Good.
Okay. So we're going to call the question, or did you have a question?
I just had a quick statement that I have, my position on work requirements and in Medicaid has been clear all along, but I think interim study is the appropriate thing to do at this point. Thank you.
All right. I'll call the question. All those in favor say aye.
Aye.
Any opposed? We got one opposed, 4-1. Any
consent.
opposition to consent? All right, Senator Birdsell moves consent. I'll second that. All those in favor say aye.
Aye.
Any opposed? And I'll take that out. So we have an amendment coming on 544, correct, Senator Prentice?
We do. We're
All right,
not ready
I'm
for
assuming
prime
it's
time.
not ready.
But I know we've got a week,
Yep,
so I'm
yep.
clear, yep. I am clear. Here's my notes on it.
Let's see, I'm gonna skip ahead to Senate Bill 645. Yeah.
Two amendments.
This says that Senator Reardon has an
Yeah.
amendment. I have not seen that amendment.
It's in
yet.
here.
Oh, yes, had to do with the dog racing. Yeah, okay, yeah, that's correct.
I wonder what dog racing had to do with.
Well, I've got an amendment as well, so we could
Weird.
adopt both amendments. And I'll tell you what,
Senator Lang on this.
yes,
Okay.
I'm gonna move ought to pass on 645.
Second.
Yeah, motion and a second, and then I will, I'll move Senator Reardon's amendment 0104S.
Second.
And that we discussed in hearing. If there's any further discussion, we can do it now. Otherwise, I'll call a vote on the First Amendment. All those in favor say aye.
Aye.
Any opposed? Okay, and I'm gonna move amendment 0791.
What?
Got it?
Oh. Okay.
Because you had two different.
07.
9-1, okay. That's what I
So I've moved amendment 0791. And we've got a second on that. Okay, so I'm going to speak to the amendment here. So this bill in of its own takes money from, on its surface, it takes money from tobacco tax, it takes money from alcohol, and it takes money from games and amusement and athletic exhibitions. And with the amendment that we just passed, which actually I see that we've got this too, it also takes money from dog racing and horse racing to fund the Children's Education Scholarship Fund. And I have a lot of concerns about, in speaking with the chairman of Ways and Means, what that would do if we were to implement this on its face. He shared some concerns as far as cutting the pie too many ways. So we discussed an amendment, and the amendment, what it would do is it would fund the Children's Education Scholarship Fund, but it would only do it once we hit, if and when we hit the plan year. So it won't automatically be sucking money off of those parts until we hit the plan that's been set by the revenues for the year. And it will then pull 50% of that surplus into the Child Education Scholarship Fund or Child Care Scholarship Fund. And then 50% of that surplus goes back into the general fund. So, you know, I look at this as a triggering. It would trigger the action. You know, I think it would have a little more predictability on our revenues because the state would still get the revenues that's been budgeted for, and this would be anything over and above those. Any further discussion on the amendment? Seeing none, I'll call the question on Amendment 0791. All those in favor say aye.
Aye.
Any opposed? So with that, I move ought to pass as amended.
Second?
We've got a second from Senator Long. All those in favor say aye.
Aye.
Any opposed?
I'll move consent.
Well, we got a growling over here. I don't know if that's a yes or a no. Hey, we'll go to finance.
All right.
Are you a yes or no?
I'll be yes.
All right, so it's 5-0. Senator Long moves consent. I'll second that. All those in favor say aye.
Aye.
Any opposed?
And I could take it out.
And I'll let Senator Long take that out. $6.46.
What?
I'm holding off on those for now. Because we've got to replace we've got an amendment coming on one of those. We've got a couple of other things we're working on with PBM stuff, so those will be accounted for next week or 2 weeks from now. Uh, 646.
Do you have an amendment?
I do not have an amendment on this. So much like the bill we just passed, we're still waiting for the stakeholders. Much like we passed 498, we're still waiting for feedback from the stakeholders. So given the time, I would move on to pass to keep this moving.
Second.
And a motion and a second. Any further discussion? All those in favor say aye.
Aye.
Any opposed? I'll move consent. Do I have a second?
Second.
So Senator Birdsell seconds. All those in favor say aye.
Aye.
Any opposed? And I'll take that out.
You're gonna be busy.
I have two, right? That one's headed to finance. Let's see, got that one, that one. So we heard a few bills today. 664 was one of them. Okay, you want to move that?
Interim study of SB 611.
Senator Avard moves interim study on Senate Bill 611. I will second that.
Wait a minute, I'm out of order, hang on a second.
I know, we're jumping all
I'm
around.
out of order, but I might file, hang on.
Yeah, you're out.
Yeah.
So 611
611,
is what?
interim study.
Interesting. Yeah, I'm okay with
Any further discussion? All those in favor say aye.
Aye.
Any opposed? Senator Avard moved consent. I'll second that. All those in favor say aye.
Aye.
Any opposed? Senator Avard will take that out. So just to talk about some of the ones we've skipped over thus far. Still waiting to, working on amendment for PBM reform, which would encompass 478, 547, and I think we can capture some of the ones that we heard on 6-7. What ones we heard today, which was 665. I'm working on an amendment there that will capture that. Senator Prentice is working on an amendment for 544. 546, I'm going to give 2 more weeks left on that one. 549, I need to speak with the prime sponsor. We've been going back and forth on topics on that. 612, Senator Avard, you've got an amendment you said possibly coming for that. 666. We wanted, yes, Senator Prentice.
I am working on an amendment on 666 based on the AG's comments today.
Okay.
And I know, 1 week.
1 week.
We just have a sign, 1 week, I'm in, so I'm working on it. Yes, and thank you.
I like 670, but we need an amendment.
Yeah, we need an amendment on 670.
More than what was presented.
They're gonna get in touch with us. Okay, all right. It doesn't sound like it's gonna be a much, it sounds like we can do that fairly easily. Okay.
Okay. Yeah, I might, I'm still not comfortable.
Okay. And that might also fit on 664, as I understand. The amendment that he's talking about.
Or 666.
Or 666. Yeah. So that leaves us with 7, 8, 9 bills to exec for 2 weeks.
I have 13.
Okay. Oh, yeah, we can do that.
548.
548. All right, we can keep going. So I move ought to pass on Senate Bill 548.
Second.
Yes, Cole just passed that one out. So this is actually an amendment that has come from the Department of Insurance. I asked them to work on something. They said that they think that there's a path forward. They've, as I understand, they've been in contact with all of the stakeholders on this. And this was a negotiated compromise to 548. So as you recall, there was this, when there's a disagreement with a provider contract, there was going to be a joint letter. And what the amendment does is it essentially gives the Department of Insurance the authority to come up with a template letter. So it's not like you've got two disagreeing parties and now have to come together and write a letter together. This would give the commissioner the ability to write a joint letter that both can sign and release to their members. And then on page 2, line 14, it sets out the criteria that if a health carrier does not use the standardized notice, it gives the the instructions on how to move forward with that.
Does this affect the fiscal year at all?
I'm under the impression that it would not. I don't have a solid answer for you, but I was under the impression it would not.
So did you move 0798, 798S?
I think you just did. Senator Avard moves 0798S, and I second that. It's my amendment. So if you need to swap that around, we can do that. So, any more discussion on Amendment 0798? All those in favor say aye.
Aye.
Any opposed? So the motion is ought to pass as amended. All those in favor say aye. Yes.
Aye.
Opposed? I'll move consent. Senator Avard seconds consent. All those in favor say aye.
Aye.
Opposed? And I can take that out. Senate Bill 609, improving screening for treatment of blood clots. Do we want to discuss that?
So what number again?
609. I'm going to move interim study on that.
I'll second that, and if I can speak to it.
Yep.
So thanks, Chair Rochford, for making the interim study motion. I think not to diminish the, the testimony of that mom that we heard, to come forward and have to talk to us about her loss. She was very brave. But what I do know is that there's two things. One is that there's standard practices already in place in healthcare facilities for patients when they're in the facility or when they're being discharged to monitor for and prevent to prevent blood clots, number one.
You know those words. Come on.
Yeah, DVT,
Yeah.
RDP. I think that is important. The other thing is that we heard some testimony from the Hospital Association, and I think that this is key, that there is this commission that looks at what I believe this was an adverse event. Okay, and we can't focus on that commission and make a change in the language to only look at one type of adverse event, but it is there. It is a quality, let me, if I can pull it up, it is a quality commission that has the authority and is the appropriate place to look at this. If we interim study it, then we're able to hold on to it a little bit longer. And there may be a future approach that commission can make or suggest for hospitals, anybody taking care of patients that are at risk. And even when they're not at risk, these things happen. So that's what I have to say.
Yeah, and they're definitely personally aware of the situation, so they're on it.
Yeah.
And that's good. So there's plans to move on something.
Absolutely. And that's my takeaway in that, I think the bill was good. It brought attention to the situation. It made sure that people were watching this, and they are. And there are requirements by CMS federally to screen, and there is a standard of care there. And again, not to diminish the experience, as it was a horrible experience. I mean, a tragic experience. But I think that, even without the legislation going forward, the issue has been addressed and will be taken care of.
RSA 151 G7, I believe it is, the Healthcare Quality Commission.
Yep.
Right.
So any further discussion? So the motion is interim study. All those in favor say aye.
Aye.
Any opposed? Senator Avard moves consent. I'll second that. All those in favor say aye.
Aye.
Any opposed? And I can take that out. Unless you guys are, any of you on it.
You want me to take it out?
Sure, you can take it out.
Yeah, that's one less.
All right.
We've got a lot to do. Sophie, I'll take that out.
So I don't have that ready yet. We've got another revision coming to that. So that will be ready next week. It'll probably be ready tomorrow. The other thing is just to, Senator Ricciardi had Senate Bill 614, pooled risk management programs for the benefit of child care centers and foster family homes.
What number?
614. We've got an amendment coming on that. I talked to the Department of Insurance. They're working with her to do that. The last thing they're working on right now is definitions. So they will have something for us on that soon. I know insurance has been swamped because we've been swamping them with a lot of stuff. So that's where we're at. I think that's all I have ready for today. Which we got through a big chunk, didn't we?
Motion to move out of exec.
Wait a minute, what is, there's a word.
Did I miss something? Okay. So we will, so next 2 weeks, we'll meet in 2 weeks. We'll be dealing with SNAP. Yep. We'll be dealing with pharmacy benefit managers. We'll be dealing with, that will encompass that in the PBM stuff. Childcare, we've got harm reduction needles that we have to deal with.
Do we have any bills that we're actually gonna be hearing that?
So
That's what I was gonna,
Yeah,
Yeah.
and maybe you and I can look at after we get done here, we'll look at it. Actually, let's move out of executive session. I make a motion. All right,
Motion to move out of exec.
all those in favor say aye.
Aye.
So with the business being done for today, we will be adjourned for 2 weeks.